specificity and the high affinity anti-TN antibody. The second part is to demonstrate that the expression of TN is positively associated with the degree of malignancy in prostate, breast, colon, cervical, oral squamous cell carcinoma, and pancreas cancer. And the third part is to apply TN vaccine for cancer treatment in tramp mice. We have found that TN vaccine can protect against the spontaneous prostate cancer formation in transgenic tramp mice. Before I go into details, I would like to provide a brief introduction of TN. TN antigen is do you have it? Oh, okay. Yeah. TN antigen is N-acetylgalactosamine, all linked to serine or threonine, which is one member of tumor-associated carbohydrate antigen, often offered to mucin-type carbohydrate. I will now go into the first part. We have used the linear array epitope technology to develop TN vaccine, which induce anti-TN antibody with high specificity and high affinity. What is the linear array epitope immunogen? It contains two parts. One is the constant region of the heavy chain of mouse antibody designated as mouse Fc. The function of mouse Fc here is to deliver TN immunogen into antigen-presenting cell in order to activate the T cells. The second part is the multiple copy of cysteine-rich peptide in linear array for TN conjugation as a result to activate the B cell. The TN with NaCl maleimide will effectively to conjugate to the cysteine-rich carrier protein through N-maleimide and the SH group of cysteine for TN conjugation to effectively activate the B cells. TN immunogen can efficiently enter antigen-presenting cell through Fc receptor, followed to activate the T cells. On the other hand, the TN conjugated to cysteine-rich peptide would lead TN in a form of clustering. After TN binding to the B cell receptor, the TN conjugate can cause B cell receptor clustering and activation of B cell. Thus, the linear array epitope TN immunogen can activate T cell and B cell. As a result, this leads to activate the immune response and generate high affinity and high specificity anti-TN antibodies. This slide shows TN with NaCl maleimide is effectively to conjugate to the carrier protein in a dose-dependent manner. As TN NaCl maleimide increase, the conjugation to carrier protein efficiency increases. As shown in this slide, we use TN immunogen. It can effectively induce anti-TN antibody with high specificity we have carrier protein conjugated with various carbohydrates, and only the carrying TN can react with anti-TN antibodies, suggesting that anti-TN antibody is TN binding specific. We also examine the binding specificity of anti-TN antibody in HeLa cells by competition assay. We add various amount of free-form TN to pre-incubate with anti-TN antibody, as shown in this slide. Free-form TN can prevent the anti-TN antibody binding to HeLa cells in a dose-dependent manner, suggesting that anti-TN antibody is TN binding specific. Using our TN immunogen, we induce the anti-TN antibody, and most of anti-TN antibody are IgG1 class, rather than other class of antibody. The anti-TN IgG1 antibody thus mediate the cytotoxic T cells to kill cancer cells through the mechanism of antibody-dependent cellular cytotoxicity, ADCC. The second part is to use the high affinity and the high specificity anti-TN antibody to examine the TN expression in various cancer tissues. We find that the expression of TN is positively correlated with the degree of malignancy in prostate, breast, colon, cervical, oral squamous cell carcinoma, and pancreas cancer. This slide shows the expression of TN is positively correlated with the degree of malignancy in cervical cancer. High level of TN expression is found in moderately to poorly differentiated tumor, and weak TN expression in well-differentiated cervical cancer. This slide shows the expression of TN is positively correlated with the degree of malignancy in colon cancer. We have examined 64 colon cancer tissues. As shown in the left panel, the TN expression is weak in well-differentiated colon cancer, and the TN expression increased from moderate to poorly differentiated colon cancer. The results are summarized in the right panel. The TN expression is correlated with the tumor size and the AJCC stage and the differentiation status. In prostate cancer patients, we also find that the expression of TN is positively correlated with the degree of malignancy. The TN expression correlated well with the tumor size. With the tumor size, differentiation stage, and the Gleason score and the PSA level. High expression of TN found in patients with high PSA level. The expression of TN is positively correlated with the degree of malignancy in breast cancer. The prognosis of breast cancer is very bad in high TN expressed patients. The expression of TN is also positively correlated with the degree of malignancy in oral squamous cell carcinoma, OSCC. When OSCC is more malignant, it's expressed more TN and more NF-kappa B, but the expression of STN is the opposite. This slide shows the positive correlation of TN expression and the patient survival. Patients expressed with high level of TN have poor survival rate. On the other hand, patients with high level of STN expression have better survival rate, so TN may be used for prognosis marker for OSCC. This slide shows overexpression of TN in poorly differentiated pancreatic cancer and weak expressed in well-differentiated pancreatic cancer. The third part will be TN vaccine for cancer treatment in tramp mice. The following result will show you that TN vaccine can protect against the spontaneous prostate cancer formation in tramp mice. This slide shows the diagrammatic representation of the temporal development of progressive prostate cancer in tramp model. The tramp mice express SV40 large T antigen under the regulation of probation promoter. Therefore, SV40 large T antigen only expressed in prostate. As a result, it's transformed normal prostate to prostate cancer. After around 8 weeks, after birth, the tramp will have mild hyperplasia. After 12 weeks, severe hyperplasia develops, and after 14 weeks, neoplasia develops, and after 18 weeks, the cancer will spread to other organs. TN expression was found both at the start of the development of prostate cancer in prostate and at the spread of cancer to the lymph node after 18 weeks. We then treat tramp mice with TN vaccine. Treat tramp mice without TN vaccine treatment had a 50% survival at 39 weeks, and all the tramp mice died at 51 weeks. TN vaccine treated groups will still have 75% survival even after 55 weeks. This study suggests that TN vaccine can protect against the spontaneous prostate cancer formation in tramp mice and prolong its life. This slide shows TN vaccine reduce tumor volume and also prevent the prostate tumor metastasis to liver and to kidney. So TN vaccine not only reduce the TN expression in tramp mice, but also make the tumor microenvironment benign. In summary, the expression of TN is positively correlated with the degree of malignancy in prostate, breast, colon, cervical, oral squamous cell carcinoma, and pancreas cancer. We have successfully developed TN vaccine, and this TN vaccine can protect against the spontaneous prostate cancer formation in tramp mice. Finally, I would like to thank my collaborator, Professor Nei Xin, from Department of Pathology, National Defense Medical Center, Taipei, Taiwan, and Professor Lin Junchen from Department of Chemistry, National Tsinghua University, Hsinchu, Taiwan. Thank you for your attention.
Any questions?
Yes.
So are you suggesting that TN antigen is tumor specific?
Yes.
Because when we look, for example, on slide 13 showing colon cancer, we see a lot of staining within a stroma. Looks like lymphocytes that are positive and endothelial cells are positive. If we go back to slide number 13. So maybe it's not necessarily tumor, but we are influencing the microenvironment. And maybe
which one?
Game of
number 16
15.
or 15.
13, I think it was colon. Yeah.
Mm-hmm.
Yeah, if you could advance, you show colon cancer, I think. Maybe I'm wrong with my numbers.
Like that's 15.
This is number 13.
Yeah, so maybe it's 15, sorry. Yeah, if you
Or the 14.
If we look into stroma where there is no tumors, there is quite a positive staining in what you call it moderate. So in general, you know, glycoantigens are ubiquitously expressed and
On the cell surface.
yeah, not only in tumor, but we know that it's basically protective mechanism to change cell charge so they can interact. So maybe it's just a game of, you know, amount of expression instead of specificity of this particular antigen for tumor cells.
Well, in the early days, people get the antibody against the carbohydrate. They immunize cancer cell to mice and then screen the antibody which can distinguish cancer and normal tissue. And then later they try to find the epitope of the antibody. So in the early stage, early data, the anti-carbohydrate is not specific. And we generate the anti-TN antibody is from pure chemical moiety. So, and as I showed in the early slide, it's very specific to TN.
Yeah, but
So,
for example, of blood groups have hundreds different antigens.
right,
They
right.
don't express ubiquitously.
It's not cross-react with other carbohydrate, as I show here. Yeah, we test the various carbohydrate, and only the protein carry TN can react with our anti-TN antibody.
Yeah, I'm not questioning specificity of your antibody, but expression of different antigens which are related to carbohydrates are different through us. If you try to check expression of carbohydrates antigen on our red blood cells, I guarantee you it will be 100 different phenotypes in this room.
But not for TN, but not for TN. I didn't show you the control experiment. We test a lot of normal tissue, and the result is negative. Yeah. Okay.
Okay, so now we go on to.
Want to use that one?
Thank you very much for giving a chance to talk here. I'm Kazuaki Nakane from Osaka University. I belong now Faculty of Medicine, but my background is mathematics. By using mathematical theorem, I would like to analyze the image of colon. So the beginning of my talk, I would like to show my numerical result. Start. This is a colon tissue. We can detect of interest by using my laptop computers. Now I'm calculating by using less than $1,000. It's over. So, please look at this window. We put the color tile on the region of interest. Here is black area. And here we get the cancer area. But we have false positive area around here and around here. So I would like to explain this architecture and algorithm. So let's start my talk. Okay. This is the context of my talk. At first, I would like to explain our problem and explain our method and the result I have shown, and conclusion and discussion. This is our problem. This is a colon tissue. All of you know, here is tumor area and dysplasia. A pathologist decides his diagnosis by the information of shape and area of tissue and entire background and so on. But how can make the support system by computer? So summarize the known result of computer method. At first, general method, processing based on the pixel information. We can easily measure the size of grains, decompose the colors, add noise cancel, edge detection. It's very easy, but we cannot detect ambiguous object and no structural information. It's very difficult to identify. So, Fourier analysis method. It's very powerful tool, but no periodicity. The result has no meaning. Even the normal tissue, there's no periodicity. So it is very difficult to apply this method to pathological something. So let's try pattern matching theorem. But this accuracy depends on the amount of the library. Advanced CPU for pattern matching is needed. So I guess there is no effective system. The cost is very high. So we propose a completely new different method. This is our method. By using the homology theorem. What is homology? Homology is a concept of quantitative estimation of connection. The tissues are formed by connection. So by using the concept of homology, we quantify the degree of connection. The advantage is the result will not be affected by the difference of individual forms. We can analyze the image that has no periodicity. Processing speed is very fast, I have shown. But weakness, it's very difficult to understand this idea. So I would like to explain this idea now. Not so difficult. Relax. So I would like to explain some important index and ideas. coffee cup by using a continuous transformation. But the number of holes is the same. We call that is topological invariant. To express the topological invariant, we need this kind of equation. Very difficult equation. It's very difficult to understand. But why we need this kind of expression? I have a question. There are two figures. Can you change this shape to this shape by using a continuous transformation? Can you?
I'm not sure, I don't care, but I think it may be possible.
Maybe possible, yes, possible. But how can we do it? Spread this whole. This transformation is very difficult. But through this, then we can change here. First look, we cannot make this shape to this shape. But really, we can make this to this. So we need the equation. So, and secondly, the batch number in two-dimensional. In two-dimensional case, homology concept is very easy to understand. So there are two connected figures. So B0 equal to 2. And there are three circular holes. Surrounded area, 3 surrounded area, B1 equals 3. This is very important number. I will use this number, the surrounded area. So please look at this figure. This circular hole is the telephone center, telegram center. And this H is telephone line. So how can estimate the connectivity of this figure? So let's count the edges. Very easy. But if we add one connection, there are two surrounded area appear. So this is the Euler formula, vortex minus H plus phase equal to 1. So to count the number of H is equal to the count of phase, namely surrounded area. That is our concept. So let's try to apply to this kind of image. How can I apply? Z-axis is a grayscale. We can make three-dimensional images. So we decide the threshold, Z-axis, and we make binarized images. So this white spot is surrounded by the black area. So let's count the number of this white spot. The number of white spot is robust. We change thresholds. And this is a graph of batch numbers. Very robust movement. So we decide by using the RGB distribution. So around here, so it's very easy to detect the threshold. So we decide the threshold, and we focus the tumor area. There are many white spots and normal area. Not so many white spots. So let's divide several areas and count the number of white spots. And high number area, we put black stone. So it coincides, maybe it's pathological diagnosis. So this is whole slide image. By using the virtual slide, we divide several images and let's count the number of holes. So we get this result. So I would like to show another examples. There exist lymph follicles and maybe well differentiated cancer areas. So this is our result. Nextly, something strange around here and here. So we can detect the strange area. So this is consistency result. Very small false negative, but false positive rate is not so very high areas. But itemized statement of false positive, cross section of inclined grants I have shown. This is 73. So if we can detect by using the maybe pattern matching theorem, we can reduce this false positive area. And this is false negative. Please look at the center of this image. There exists pol2 solid type cancer. So we cannot decide, we cannot identify this kind of cancer. But colon case, not so many. So by using pol2 detector I'm now making. And recently, we brush up my method. By using the distribution of index, we can identify the cancer types. But now applying patent, so I cannot explain this in detail. But next week I can explain, maybe, I hope. So this is the discussion. To detect tissue with high cell density area, we establish a prototyping for automated cancer image analysis I have shown. So we find a good process to choose the binarized parameter. We have many false positive, a few false negative. We should improve the binary threshold detecting method, I think. So this is a future work. By adding another algorithm, improve the accuracy, minimize the false positive, eliminate the false negative, expand applicable cancers. Now I'm trying colon case, but I would like to expand stomach, lung, breast, and so on, if I can, I hope. Make a fully automated diagnostic system. This is our goal. So this is our plan. Pathological diagnosis proceeds this process. Here, pathological diagnosis procedure. At first, pol2 screening and detect the region of interest and register false positive and automatic differentiation of chronical neoplasm. I'm a mathematician, so I hope I would like to, I'm looking for the collaborator of my study. If you are interested in my study, please come to me. So, thank you very much.
Very interesting idea. I am a GI pathologist, so it would be very up to you show the slide that I made the diagnosis. So I'm not sure what's the purpose of this digital imaging to make the diagnosis without pathologists, or what we're trying to do.
Why? In Japan, the number of the pathologists is not so many, and they have very heavy duty. It is completely different from United States. So I would like to make support system for diagnosis. So that is my motivation.
The other question is, there are multiple types of cancers. So you're looking at adenocarcinoma, but what about other, like diffuse type cancers? You probably cannot separate from the other things. Mucinous adenocarcinoma, squamous cell carcinoma. So they're so different. Sometimes you get complex cancers have different areas, how your models work on that one. I just feel like I can make the diagnosis in 2 seconds with your model, probably take 30 minutes or something.
I have two questions. What's the software you're using? What software are you using? What is the software?
Software. I made.
Homebrew. In C++ code?
C++.
And how do you think you're going to get a pathologist to collaborate with you on a project to put them out of business?
For business,
Only in Japan, I guess.
No, I think it's a much more general question. I mean, it may seem like a joke, but I don't think it is a joke. And the other thing about it is that this has wide applicability in non-neoplastic disease, where you're less, you know, you're looking at a process that is maybe the same throughout the tissue or is manifested throughout the tissue. There are not these different regional differences, and yet there are many non-neoplastic conditions where there's a huge volume of slides to look at.
Yes.
And it's the same problem. You know, in the US, a lot of kidney biopsies are looked at by people who have never had a kidney pathology mentor. They were just told by a chairperson somewhere, go to the books and learn this. And so, to a certain extent, your system is not just competing with people who have mentored knowledge, but people who were just mentored by books, never by a flesh and blood human being, and who are assigned to an important task of you know, interpreting biopsies without ever talking to a real expert in that area. It's shocking that that would exist, but it certainly does. Yes.
Well, I want to thank you very much for your presentation. As a joke, I wanted to tell you that and in the USA, there are FDA-approved computer-aided diagnostic system who basically screen cytology slides and point to area of interest that afterwards are going to be seen by somebody who is proficient in making a diagnosis. And of course, this has to do a lot of with liability in making the diagnosis. I do believe that your the development of your software is extraordinarily applied in a certain situation, because how our can make this diagnosis easily, but your application in homologous
homology.
yeah, it's tremendous, I think. And yeah, I'd like to speak to you.
Thank you very much.
So most of
overview, the unmet need that's there in India in this particular concept, and some of the clinical testing that we're doing, and the results and conclusions. So a very interesting thing is happening, as we all know, in electronics and devices. They're getting smaller, they're getting thinner, slimmer, they're getting more portable, they use less energy, and so that is an inevitable thing that's happening. So this is not just restricted to consumer electronics, but it's getting into diagnostics. And we see all kinds of devices, as shown here, that have integration of different concepts of electronics to make, so you especially have like these, everything is smartphone based, a lot of them are smartphone based, and you have integration of technologies. Like recently there was a couple of weeks back in MIT, they developed a spectrometer that's behind the lens of a smartphone, so you can do a lot of things with that. So, and similar, we see this happening all the time. So why am I talking about this? So in India, we sort of see a dichotomy. On the one hand, it's a terrible physical healthcare infrastructure where the doctor to patient ratio is like 1:2,000. And in some of the rural hospitals, doctors, people have to travel a huge, long distance to go to urban areas for tertiary care. And so there's a lot of problems in the infrastructure that's there in the healthcare. That's on one hand, while on the other, it has a very extensive mobile telecommunications infrastructure. It's in fact the second largest in the world, with more than 930 million users. And the 610 out of 640 districts have 3G coverage. With the this is actually 2012, so I think it's better now. So you see these two sort of situations. You know, on the one hand you have a very limited infrastructure, healthcare, and on the other hand you have a really good mobile telecommunications. So I guess can we bridge these two? In other words, there is a huge potential for implementing mobile telehealth solutions. So so before we get into the details, so Siemens got interested in this. This is a big problem, not just for India. I'm sure if you project this to Southeast Asia and Africa and so on, this problem exists. So we wanted to test, certain technologies. So I'm going to tell you what that is. And we chose a use case scenario of oral cancer. So very quickly, it is the 6th worldwide, and tobacco and alcohol are among the highest risk factors. And the very interesting thing about oral cancer, like other cancers, is that early detection is absolutely key in prolonging the survival. You have early, which means screening will be a very good tool here. And in India, it's 40% of all cancers are oral cancer, and it is the #1 cancer for men in India. So that tells you a lot. And #3 in women, and even in the US, about 37,000 new cases of oral and pharyngeal cancer are diagnosed each year, and about 8,000 deaths per year. So that's why we wanted to choose something where early detection is important, meaning screening is really important. So that's where, and in terms of the unmet need, I told you that there is a need for early, minimally invasive screening and triaging. So because if you go for like invasive methods, people are not get them. And the idea was to triage them using a low-cost mobile connected platform. So as I told you, pathologists are, there are rare species in India, and we want to see if can we, especially in the rural areas where the tobacco use is very much. Have a lot of this problem, but rural India doesn't have pathologists, so can we connect them pathologists to the rural India? So the University of California, Berkeley came up with this concept called the CellScope. It's actually a system, it's not just a device, which is a fusion of a lot of concepts I'm going to show you. It's basically mobile telemedicine, where you project diagnostic services in underserved areas. And how do you know so the CellScope started off initially as a curiosity apparently in an undergraduate lab in UC Berkeley, in the lab of Dan Fletcher. So it has evolved now. So initially it was this feature phone attached to this microscope optics. Then it actually became an independent unit by itself, where you have the optics, and using a periscopic mechanism, you have this illuminator, a little torch, LED torch. You have the slide there, and the image appears on your smartphone. And then they said, you know, why restrict ourselves to a smartphone? Can we use a tablet? And so that is showing here. You actually have a tablet there. And then they said, okay, well, you still have to use manual vernier, you know, like to move the slide on the X and Y axis, you have to use vernier. Can it be automated? And the device that we have now, this is an iPad that's kept on this device. You load a slide here, and when you move the by touch, when you move, it's a gesture control where you can move the slide not by actually touching the slide, but by moving it on the screen of the iPad. So that's sort of, and the good thing about this is it has a feature called automated scanning, where you can ask the device to take X number of images, whatever, 100, 200 number of images, and what it will do is it will scan the slide, raster pattern, like the typical classical, sort of like that, and it will take any number of images that you want in a random fashion. It can do an autofocusing at each. So if before it takes an image, it will do an autofocus and take the best image, and go on to the next one and so on. So that's the kind of device that has currently evolved. So the CellScope has already been used to screen for certain infectious diseases, as shown here. Tuberculosis, hepatitis C, the blood fluke or schistosoma, and lower, and many of these publications are pretty recent. In this year itself, there were 3 publications. So it has been successfully tested for its screening capabilities in infectious diseases, and this is the first experiment in oncology. So our collaborators, as I told you, we collaborate with the Dan Fletcher's lab at Berkeley, and our clinical partner for this study is the Majumdar Shaw Medical Foundation, which is part of the Narayana Health Group in India. So we had two objectives when we started the study. First was, to compare the CellScope against conventional method of cytology for oral cancer screening, which means, so let's say the images are taken by the CellScope and are seen by a remote pathologist, and they give a diagnosis. Compare that to the actual slide, the cytology, it's the cells on the slide, so the pathologist sees that. So can we compare these two? What happens when you compare these two? The second objective was, if you evaluate the brush biopsy CellScope combination versus the punch biopsy conventional microscopy combination, which means, so in the study the idea was to do brush biopsy. The brush is a simple cervical brush itself was used. So if you take a brush biopsy of the lesion, oral lesion, and send the images on the internet and ask the pathologist to look at it, so that's your brush biopsy CellScope combination versus a classical scalpel or punch biopsy and followed by conventional histology. So if you compare those two, what happens? So these are the two objectives that we had for the study. And so patient recruitment was done. We had IRB papers, everything was done. And the inclusion criteria was patients more than 18 years of age and anybody who had a suspicious oral mucosal lesion. And of course, patients were briefed on the purpose and plan, and only patients with consent were considered for the study. And these are the exclusion criteria. So the idea was this: for the primary objective, as I told you, to compare the CellScope against conventional cytology. So the patients would walk in with a suspicious lesion. After voluntary consent, record the medical history, perform a quick brush biopsy. It's a simple brush as shown here, the Cyto brush that's currently used for cervical cytology. And we had a sample preparation method of very fundamental method. It is a quick wash of the cells after centrifugation, staining and fixing on the slide. And then the technician would scan the sample with the CellScope device, and they would upload the scanned images on the server. And then what would happen is we had two pathologists who would independently, they would review the images after secure login and password. They would access the images. They would in fact even annotate the images. So we actually created a method by which if a pathologist sees a cell as suspicious, they would just click on the cell, and they could actually annotate the images. They would also record the diagnosis. And then independently, the slides of the patients were also given to the pathologist by conventional microscopy. And so it was all blinded, so the pathologist would not know which slide belonged to which patient, and the two pathologists did not know what was the diagnosis given by the other pathologist. So it was done in a blinded fashion. The secondary objective was performed as follows, where the patient underwent a scalpel biopsy, and after the scalpel biopsy, the histology was done according to normal regular protocols. And again, the two pathologists would review the histology slides, did the diagnosis, and then there was a comparison where we also looked at inter-observer variability and correlation between the two combinations, as I told you, the brush biopsy CellScope versus the punch biopsy histology. And so as I told you, this is preliminary data where I have taken about the first 32 patients worth of data. And sorry, it's a very busy slide, but I just want to highlight one particular thing, that there was a very high proportion of patients exposed to alcohol and tobacco. This was expected, but it was really big. I mean, tobacco and alcohol use was seen about in 78% of the patients. So almost 8 in 10 people had tobacco and alcohol. And especially in India, and which is common in Southeast Asia, chewing of tobacco was seen in 76% of the people. So it is a very high correlation, and we were not surprised. This is known, and there are certain types of tobacco. I mean, the habits, like especially they like to keep the tobacco in between the gum and so they sort of open their lips and they keep that cut there. And that is the area where, in fact, we see a lot of oral cancer. These are the sort of profiles of the patients. And so, how are the images? How do the images look under a CellScope? So initially, when we started looking under the CellScope, we had this issue where we saw this annoying sort of yellowish background, and it was a sort of an illumination problem that we solved. It was not a big deal. And this is sort of images showing squamous cell carcinoma. This patient was later found to have squamous cell carcinoma, where you see these hyperchromatic nuclei. This is leukoplakia, where there's actually a paucity of cells. As you guys know, leukoplakia has a hardened surface, so it's difficult to get too many cells. So when we look at the first of all the kappa analysis, which is basically looking at the inter-pathologist agreement. So I mean, there's a lot of numbers here, but there was recently good 0.78 when you look at the diagnosis based on CellScope images. When you look at the diagnosis based on cytology slides, the kappa was again pretty good, 0.75. So, and according to this particular agreement values on kappa, you see that this is called a substantial agreement, and the 95% confidence intervals are also pretty good. So, which means that the two pathologists went between what they said. So, there is validity in looking further for the results, because if the two pathologists don't agree at all, there's no point in going ahead with the study with the results. So having looked at that, then we looked at the analysis of the primary and the secondary objectives, and as you can see here, so this is the primary objective where we looked at the sensitivity and specificity Interestingly, the specificity was excellent, and the sensitivity was also good. If you look at the secondary objective, which is where you compare the cell scope diagnosis with histology, there the sensitivity falls. And so this is something that interestingly we observed. And so then we thought, can we, so this, what's interesting here is, so you look at cytology and cell scope diagnosis, you have good sensitivity, but when you look at the gold standard histology, there is a lack. So what is happening? So then we thought, can we look at actually cytology itself? If you look at conventional cytology, oral conventional cytology done by brush biopsy versus gold standard, that's histology. There we see that again, the sensitivity is lower. Of course, it's not as low as in the cell scope, but it is lower. So perhaps the brush biopsy based cytology itself, the technique itself has a lower sensitivity compared to histology. And this is not completely new information. There are papers which talk about, in fact, there are papers which say that if you use a cervical brush, the way it is designed right now, like a cyto brush for oral cancer, it's not a good idea, because you may not hit the basal membrane where actually the initial stages of malignancy originate at the basal membrane. So you may not actually hit that. And there are companies which sell you brushes designed especially for oral. There's one company which sells called Orcelex. Orcelex is a brush that has more stiffer bristles, and actually it picks up more cells from the basal membrane. So that's something that we are thinking that, considering the results of this initial part of the study, perhaps in leukopplakia, it may be better to use the Orcelex brush so that you can actually dig in more cells where there's a paucity of cells. So those could be the potential reasons. So the study goes on. We continue to, the idea is to get about at least around 100 patients, and we sort of number now, but the analysis shown here is only for the first 32. So in conclusion, we feel the cell scope is definitely, there's good opportunity in telemicroscopy based disease screening, and we used oral cancer as a use case scenario in India. There was good agreement between the two pathologists using the cell scope. Has excellent specificity, but so in terms of sensitivity with reference to cytology is good, but the sensitivity with respect to histology is lower, and we need to correct that. And there are the inherent differences between brush biopsy based cytology and histology could be the reason for the lowered cell scope sensitivity. I'd like to acknowledge a lot of people involved, including our clinical partner, Berkeley people, and our own Siemens people. Thank you very much. I'll take questions.
I have a question.
Sure.
It's a great talk. Way back when I left India in 1986, we had what called a mobile cancer unit, where they went to rural areas. I'm a little surprised why you have such a low cohort of 32.
Actually, the idea is to take 100 patients. So that was the initial plan. Where as the study went on, we saw that in the first few, like 32 patients itself, we were seeing a trend of this, good
and especially in patients co-infected with HIV and HCV. And as we know, there are several viral and health factors related to viral response which have been reported in the literature. In regard to morphometry, as you know, morphometry is a field that investigates changes in shape and size. Well, morphometry allows for the quantification of these parameters, which can highlight areas with significant differences. In recent years, morphometry has been used to better predict disease phenotypes and prognosis of disease in several fields. Well, various studies used morphometry in liver diseases. One study showed that morphometry is a good method to follow progress of liver fibrosis in patients with chronic HCV. We also know that morphometric analysis has been used in other fields. For example, it has been used to predict a clinical phenotype and biopsies taken from the colon in patients with colitis due to Crohn's disease. And it was also used to analyze cancerous cells from squamous cell carcinoma of the vulva and kidney carcinoma, which had allowed us to predict the involvement of lymph nodes and illness prognosis. Well, based on this information, we had hypothesized that at the same level of inflammation or fibrosis, according to Medavir method, there are morphometric differences in regard to inflammation and fibrosis, and differences in the texture of liver tissue in different patients. These differences may be related to the response to antiviral. So if this is true, these data would be an early predictive factor to response of HCV virus and to antiviral treatment. Based on this hypothesis, we had both two major aims to our study. The first one was quantification of histological findings from patients with chronic HCV using computerized morphometrics. The second one was prediction of response to treatment in chronic HCV patients using the baseline histomorphometric findings. Well, our study design, our study is a retrospective one. All the clinical data was blinded to patient identification, and the histomorphometric analysis has been blinded to patient identification or previous histological information. Well, patients have been included in our study according to different criteria. We had included HCV genotype 1 and who were naive to antiviral treatment and who had viremia level above 400,000 international unit per ml prior to treatment. And we had excluded patients who were the opposite, and patients with of another liver diseases, or alcoholic patients, or patients with co-infection with HBV or HIV. Well, this is a scheme to simplify our study design. As you can see here that we had included 60 chronic HCV patients with genotype 1. These patients were divided into two groups. The first group were 30 patients who reach SVR, which is sustained viral response. That's mean who respond to treatment, and 30 patients who did not respond to treatment or had partial response or relapse. We called it non-SVR patients. And for each patient in both groups, we have gathered the clinical data and every histological with which we got prior to the treatment beginning, we had performed histomorphometric analysis and textural analysis. Well, as you can see, the histomorphometric analysis is the major part of our study, and I would like to highlight the stages that we had performed this analysis. Well, the slides were scanned using the dot slide virtual microscopy, and the entire slide was manual scanned. 3 to 4 representative images were recording from each slide, and we used the ImageBras BRA+7 program to analyze and quantify collagen fibers and inflammatory cells and liver architecture. We have also used the MATLAB software to analyze fractal and lacunar dimension, giving an indication of the architectural distortion in liver parenchyma. Well, this figure is only a simplification of the method that we used. You can see a simplification of the method that we used to quantificate inflammatory cells in the hepatic portal space. In image A, we can see a portal space scanned in light microscope with trichrome staining, and in image B, we can see red marking of inflammatory cells within the hepatic portal space, which is bordered in green. And here we can see also simplification of the measurement of fibrosis within the borders of a portal space. And here in this slide we can see that a convolution mask. In image A, we can see a parenchymal tissue which was scanned in light microscope, and in image B, we can see a mask image. Image C, we can see the MATLAB software analysis. Well, here in this figure, we can see the GLCM processing analysis, which can give us the textural parameters, which includes a homogeneity, contrast, correlation, and entropy. Here I would like to summarize the variables of our study. The dependent variable was response to antiviral treatment or non-response to treatment. The independent variables were classified to 4 groups. The first group were demographic and clinical variables, which included age, sex, and ethnicity, weight and height, BMI, and background illnesses. The second classification included laboratory variables, which included liver enzyme level and blood count, albumin, INR prior to treatment. The third and the fourth classification included the histomorphometric analysis variables, which included the amount of inflammation and fibrosis in the hepatic portal space. And we had the textural analysis variable like lacunarity, fractal analysis, GLCM analysis, which included entropy, correlation, homogeneity, and contrast. To analyze these variables, we had used several statistical methods. As you can see here, we had used the Pearson chi-square test to analyze the correlation between continuous variables, and Spearman test to analyze categorical variables. We have also used the discriminant analysis for the prediction level and ROC analysis curves to reach the cutoff points showing the best prediction for response to treatment. Well, now after an exhausting work and time-consuming measurements, we had reached our results. We can see here in this descriptive table that most participants in the study are Russian, from Russian origin. We can 67% in the SVR group were from Russian origin and 70% in the non-SVR group. You can see that most of our patients were with genotype A1B in both groups, and our patients were with F1 fibrosis according to the Medawar fibrosis score, and A2 inflammation grade. Well, by the univariate analysis, we had seen that age and bilirubin and white blood count prior to treatment were statistically significant. And parameters of osteomorphometric analysis, we had seen that the standard deviation of density of collagen fibers in portal space and number of inflammatory cells per millimeter square and lacunarity were statistically significant. In another statistical method, we had the discriminant analysis, we had reached another results from the demographic and clinical parameters. Only hemoglobin prior to treatment was statistically significant, and we had also architectural parameters including contrast, correlation, and lacunarity were also statistically significant. We had used the model of Fisher linear discriminant function equation to make a formula which included these parameters, which were histomorphometric analysis parameters, textural analysis, lacunar analysis, and clinical parameters. And by this formula, which can be used to predict response to antiviral treatment. This predictive formula is the DS, which is the discriminant score, which is included all the parameters that I have mentioned before. And by this formula, we can predict response to antiviral treatment. Well, here we can see the ROC analysis that we had used the ROC curve, the best cutoff points in this DS equation, which will be able to distinguish between response and non-response to treatment. The area under the curve, which is the accuracy, we got a 0.773 accuracy, and the specificity of this formula was 100% and sensitivity of 90-30%. The cutoff, we also calculated the relative weight and cutoff point based on the figure below. The cutoff point was minus 15.7. That means that based on the RAC analysis, if the DS equation was above minus 15.7, this predicts response to antiviral treatment, while DS equation below minus 15.7, this predicts the failure of antiviral treatment. And now I would like to finish with the conclusion. Our study indicates that apart from predicting treatment success, this study showed that histological parameters of liver tissue have prognostic significance, and histomorphometric and texture analysis using histomorphometric method is promising, and it may contribute to developing an expert-guided automatic system predicting response to treatment in chronic HCV patients. This method may be used at an early stage when histological changes are minimal, which may affect choosing suitable treatment for each patient. As far we know, this is the first study of its kind in the world which tested the relation between morphometric parameters and the chance for treatment. Of course, we need further research in the future, both in patients with HCV and in patients with other liver diseases, in order to check if there is a relation with prognosis and treatment response. Well, I'd like to thank you, and thank you all for listening.
So how long does this take, and how does it compare with, like,
Valproic acid is commonly used for treatment for epilepsy. Recently, groups investigated that VPA blocks histone deacetylase with less toxicity to commonly used TSA. And we reported that VPA promotes neuronal differentiation and extension of processes of them via the H-type inhibition. In this study, we tried to regenerate the injured spinal cord by using neural stem cells and valproic acid. At first, we made spinal cord injury model using ING impactor with 90 kilodynes. Next, transected forebrain of green mice embryo were expanded and cultured on dishes with growth factors and used for transplantation. 1 week after injury, neural stem cells were transplanted into epicenter of injured spinal cord, and VPA was administered for 7 days to control the differentiation of transplanted cells. We made control models with neural stem cell transplantation only, VPA administration only, and no treatment. In parallel with the experiment, we checked motor function of hind limbs by BBB scoring. Once spinal cord was injured with 90 kilodyne, it is hard to move hind limbs. After 4 weeks post-injury with no treatment, little movements of hind limbs can be seen. If we treated them with neural stem cells only, we can see some improvement of hind limb motor function, as someone reported. And if we treated them with neural stem cells and VPA, motor function of hind limbs drastically improved. This is the time course of hind limb functional recovery. The blue line is dual-treated mice. The red line is neural stem cell transplanted mice. The green line is VPA-treated mice. We can see drastic improvement of hind limb movement in dual-treated groups. In order to evaluate the corticospinal tract, biotinylated dextroamine was injected to the bilateral motor cortices of mice brain and quantitated the number of labeled axons after 2 weeks. You can see labeled axon in the injection site and corticospinal tract in intact mice. The top panels are intact mice. Labeled axons could be seen from rostral to caudal area of dorsal funicles of spinal cord. In injured mice, most axons are disrupted at the lesion site, and no labeled axons could be seen in the caudal area. Contrary to our expectation, we couldn't see the extension of axons from the injection site, and in spite of recovery of hind limb function in neural stem cells and VPA-treated mice. So we focused on the transplanted cells. We checked the distribution and differentiation profile of transplanted cells. Transplanted cells migrated to the rostral and caudal area of the spinal cord and differentiated into neurons and extended log processes to the anterior horn and dorsal funicles. Neuronal differentiation of the transplanted cells were promoted by VPA administrations, and astrocyte differentiation of them were inhibited. By using BDA, we evaluated the axonal damage of primary neurons. In the next step, we performed multisynaptic neuronal tracing. Wheat germ agglutinin can be transferred across synapses to second and third order neurons, permitting functional neuronal circuits to be tracked in the CNS. We injected WGA-expressing adenoviruses into the motor cortex. In an injured mice, WGA was detected as intracellular granule-like structures in neurons localized in the ventral horn throughout the spinal cord. In untreated spinal cord injury mice, WGA granules were almost absent from the caudal region. Surprisingly, although we couldn't observe CST axonal extension through the lesion site, WGA granules were clearly present in the caudal large neurons located in the spinal cords of mice treated with neural stem cells and VPA. Moreover, transplant-derived neurons in or close to the lesion site contain WGA granules, which were received from more rostral neurons. This data suggested that WGA was conveyed through the lesion site to the caudal area via transplant-derived neurons. Considering these findings, it seems that transplant-derived neurons reconstructed the disrupted neuronal circuits, thereby acting as relays for transmitting signals between endogenous neurons whose interconnection had been abolished by the injury. In support of the notion of a relay function for transplant-derived neurons, immunoelectron microscopy revealed that GFP-positive transplant-derived neurons received projections from the endogenous neurons and that the axon terminals of transplant-derived neurons made synapses with endogenous big neurons localized in the ventral horn. To determine whether the transplanted cell made a direct contribution to the functional recovery of hind limbs after spinal cord injury, we performed specific ablation of transplanted cells using the toxin receptor-mediated cell knockout method. For this purpose, we prepared neural stem cells from the embryonic forebrains of GFP luciferase transgenic mice and diphtheria toxin receptor GFP and luciferase transgenic mice. These cells are transplanted into the epicenter of spinal cord injury model mice. If we administrated luciferin, we can detect light from transplanted cells via skin by using the in vivo imaging system. And if we inject diphtheria toxin, only the toxin receptor expressing cells are ablated. In a parallel way, we check the hind limb motor function once a week by BBB scoring. Transplanted cells could be clearly tracked by the IBIS. 6 weeks after injury, we injected diphtheria toxin. Surprisingly, only the toxin receptor expressing cells are ablated from the injection site. Almost all of the transplanted diphtheria toxin receptor GFP luciferase neural stem cells were specifically ablated from following diphtheria toxin administrations. Furthermore, after ablation of the transplanted cells, the BBB score of it declined rapidly to levels similar to untreated mice. This data indicated that the transplanted cells made a direct and measured contribution to the functional recovery of hind limb movement in the spinal cord injury model mice. This is a diagrammatic summary of deconstruction and reconstruction of neuronal circuits in the spinal cord. In the acute phase, CST fibers are disrupted and hind limb movements are completely lost. In the chronic phase, very few CST fibers are restored. After neural stem cell transplantation and VP administration to the injured spinal cord, neuronal differentiation of transplanted neural stem cells greatly enhanced and drastic functional recovery could be observed. WGA is conveyed through the lesion site area via transplant-derived neurons. Once transplant-derived neurons were ablated with diphtheria toxin, hind limb function were abolished, suggesting that transplanted cells directly contribute to the functional recovery in hind limbs. Ablation of residual local neurons in the lesion site by NMDA led to the complete impairment of hind limb movement, suggesting that locally existing endogenous neurons also play an important role in the improvement of hind limb motor function. In this study, we named the dual treatment HDAC inhibitor administration and neural stem cell transplantation as HINT method. We hope that the method will provide any hints for regenerative therapy in the future. I'd like to acknowledge the people who worked with us on this project. That's all my presentation.
It's open for discussion.
Yes, the scaffolding is very important things. And in our case, the scaffold was made, but the astrocytic scars are very big factors. And it doesn't promote the recovery of hindering movements. So in our situations, the transplant-derived neurons made a synapses with the edge of the scaffold and scars. And that we think that we treated these mice with our transplanting and reducing the scaffold, the scars. More drastic movements can be seen, we think.
So basically, if you severe spine and you separate it, and there is no residual glial tissue, you will not observe recovery?
Yes, we made many cutting, and we can see the migrated cells and neurons making the synaptic connections around them.
Any other questions? Thank you very much.
Thank you.
The next talk is by Dr. Nure Basalu from the Acıbadem Health Group, Turkey. The title of his talk is The New Predictive and Prognostic Markers in Hepatocellular Carcinoma. Welcome.
First of all, I would like to thank you for kind invitation to the Congress organization. Today, my presentation, the new predictive and prognostic markers in hepatocellular carcinoma. Hepatocellular carcinoma is the third most common cause of cancer death and an important healthcare problem worldwide, especially in Argentina. Its incidence is increasing in many countries. Despite the development in diagnosis, advances clinical research and treatment, ACC prognosis remains poor and high mortality rate is still an important problem. ACC carcinogenesis is a multi-step process with many possible etiological risk factors, including hepatitis B and C viruses and aflatoxin exposure and the others. ACC prognosis on tumor stage, histological grade, angiolymphatic invasion, high alpha-fetoprotein levels. Some recent molecular factors such as tumor proliferative rates, nuclear DNA ploidy, levels or growth factor and hormone receptors have been used to predict clinical outcome in HCC patients. In the current study, we aim to investigate the predictive and prognostic significance of these factors, these markers in 50 cases, in 50 hepatocellular cases via bioimmunohistochemistry to assess correlations among staining intensities, clinical pathologic features, and survival rates. 50 HCC cases were stained these markers by immunohistochemistry. 48 cases had total hepatectomy and transplantation, and 2 cases had partial hepatectomy. Clinical pathologic data were retrieved surgical archives and pathology reports. SPSS 8 was employed and Fisher-Exact, Pearson-Key test, and Kaplan-Meiers were used. Most of cases were male, and most of them older 50. Most of etiologic agents was hepatitis B virus, and most of them cases was right lobe located. Most of them was multiple, and you see MELT score and other clinical features. The average follow-up period was about 38 months, and 80% of the cases survived more than 2 years. Liver cirrhosis was seen in all cases. Tumor grade and TNM stage were mostly 2. Necrosis was present 30%, and angiolymphatic invasion was seen 18% of the cases. Lymph node metastasis and tumor thrombi in the portal vein were very rare. There are some examples in our study: cirrhosis and cut surfaces, one tumor nodule and surrounding cirrhotic area, and you see multiple tumoral nodule, grade 1, grade 2, and grade 3 HCC cases in microscopic examination. CRP2 proteoglycan is a transmembrane tyrosine kinase receptor family. Its overexpression and/or amplification is correlated with neoplastic transformation, and progression is associated with other poor prognostic factors, including stage and grade, and to resistant the drug treatment. And only membrane staining is considered positive. In some studies, CRP2 positivity have been reported wide range, 0 and 92%. While some studies found CRP2 overexpression or amplification in HCC, some found neither overexpression nor amplification in HCC, hepatocellular adenoma, or normal liver tissue. Membranous or cytoplasmic expression have both been reported. Membranous CRP2 staining was not in our cases, but cytoplasmic positivity was seen 92% of the cases. You see 3 positive staining CRP2 in hepatocellular carcinoma, carcinoma cells, and 1 positive in cirrhotic liver. CRP2 expression is correlated with portal cirrhosis, tumor-grade overall survival, and disease-free survival time. Commercially, others filed is correlated histological grade, stage, and survival. In our study, CRP2 cytoplasmic positivity was correlated with multiplicity, loss of P27, and overall survival. Another marker, EGFR. EGFR is transmembrane tyrosine kinase receptor family, and it's and apoptosis. Its increased expression and/or aberrant function is correlated tumor progression and poor prognosis in many epithelial neoplasm, including hepatocellular carcinoma. Scoring of EGFR was calculated according to FLAX study. EGFR overexpression has been reported between 4 and 85% of the cases, and it's correlated with proliferation activity, stage, angiolymphatic invasion, carcinoma differentiation, invasiveness, and recurrence. However, EGFR, according to some studies, EGFR levels do not correlate with any of the main clinical pathological features of survival. In our cases, EGFR membranous positivity was seen 40% of the cases. And you see membranous positivity EGFR. In our study, EGFR positivity was correlated with histological grade, AFP levels, high AFP levels, and angiolymphatic invasion. Another marker, PTEN and mTOR and PI3K. PTEN is a tumor suppressor gene and negative regulator PI3K and ACT signaling. PTEN loss leads ACT signaling, ACT activation, and overexpression mTOR. So PTEN loss, proliferation, correlated with proliferation, invasion, metastasis, resistance of apoptosis, and angiogenesis. Evaluation of PTEN and mTOR were calculated according to this study. PTEN loss in our study, PTEN loss was 56%, and mTOR cytoplasmic positivity was seen 30% of the cases. PI3K positivity was seen in all cases. And you see here nuclear positivity in hepatocellular carcinoma cells and negativity in cirrhotic liver cells. And you see moderate cytoplasmic positivity mTOR and strong cytoplasmic positivity PI3K. Loss of PTEN and overexpression of mTOR is correlated with poor prognostic criteria. In our study, no significant correlated between PTEN, PI3K, and clinical pathological parameter, also with PTEN, PI3K, and mTOR. Only mTOR was correlated AFP levels and multiplicity. P27 is cyclin-dependent kinase inhibitor and negatively regulates cycle progression through the G1 phase. So P27 is potent tumor suppressor. Scoring of P27 was calculated according to this reference. In our study, loss of P27 was seen 92% of the cases. And you see nuclear positivity, but most of them cells negative for P27. Low P27 is correlated with poor prognosis in several carcinoma, but some studies says no relationship P27 expression and tumor size, metastasis, AFP level, or angiolymphatic invasion. But some studies, P27 is an independent prognostic for disease-free survival and recurrence. In our study, loss of P27 was correlated AFP levels, multiplicity, and CRP2 expression. ERCC1 is a KDN repair enzyme, and primary function is to repair activity in nucleotides, excision repair in damaged DNA. Its increased ERCC expression is associated with resistance of cisplatin-based chemotherapy in hepatocellular carcinoma, similar to non-small cell lung carcinoma. Scoring of ERCC H-score was calculated according to these references. And in our study, ERCC1 was observed about 38% of the cases, and nuclear positivity, ERCC nuclear positivity. Some studies increased ERCC1 expression is associated with liver fibrogenesis and carcinoma and larger tumor, but some cases suggest that ERCC expression cannot be only cause of cisplatin resistance, because they only found positivity in less than 2% of the cases, whereas 90% were cisplatin resistant. In our study, ERCC low score was calculated, angiolymphatic invasion, and overall survival. HPV was more in patient with advanced cancer stage and right lobe tumor. Tumor size larger in patients older 50 cases and HCV cases, and tumor size was calculated necrosis, AFP levels, and multiplicity was according to CRP2 mTOR overexpression, loss of P27 expression and size. In conclusion, CRP2, EGFR, mTOR, ERCC1 overexpression levels, and loss of P27 may play roles in HCC carcinogenesis and may be significant predictor of aggressive tumor behavior. These markers were found to be correlated with certain clinical pathologic features, therapy modalities, and survival rates in the current study. These findings may be in planning new targeted treatment strategies for HCC. However, large-scale in vitro and vivo studies are needed. Thank you for your attention.
Open for questions and discussion.
I have a question. How are they clinical grade antibody?
Sorry? What kind?
Are they clinical grade antibody?
Clinical?
HER2 or EGFR antibody.
I don't understand.
Can you repeat the question?
Are they clinical grade?
Clinical grade.
Yeah, in other words,
GNM stage, okay.
You mean if they are FDA approved or research?
Yeah, because I think it's the HER2 and EGFR for autism. I didn't see that HER2 state that only cytoplasm. It should be nothing. So that's why I'm surprised about this thing. Do you have quality control for example?
Yeah, yes.
From breast cancer or other state?
CRP2. HER2, yes, it's very surprising for us because HER2 only membranous. Yeah, some reports says cytoplasmic. Sorry.
I mean, when you say your examples,
Okay. Yes, we use positive controls. Breast carcinoma. Yes. Only membrane staining is considered positive, okay? Membranous or cytoplasmic expression have both been reported in hepatocellular carcinoma, only hepatocellular carcinoma. Breast carcinoma is only membranous staining, okay? But only hepatocellular carcinoma, some reports says membranous or cytoplasmic expression. And cytoplasmic expression, 90% of the cases. But no membranous staining. For only hepatocellular carcinoma, yes.
If I may comment, I'm sorry. You know, in research, there are findings that are not necessarily fully applicable in practice, but there is such a thing like an aberrant expression. So yeah, it's an epidermal growth factor and should be expressed at the membranous level. But in certain pathologic conditions, some of these markers that should be expressed whether you expect them to, like in membranous, may be aberrantly expressed in different. For example, P63, you are used to see it in the nucleus. Well, there are papers out there that describe positivity in certain cancers in the cytoplasm, and those cancers appear to be more aggressive. So this is something probably that's worthwhile to explore, but it's not necessarily not true in this project, I think. And I invite other people with experiences in immunohistochemistry to comment on it if they want.
Any other questions? Thank you. The next talk is by Dr. Tripti Shetty. The title is Assessments of Safety and Toxicity Levels of Gold Nanoparticles Using Zebrafish, Daniel Rererio as a vertebrate model.
several nanoparticles which has been present. The commonest is silver nanoparticles, gold nanoparticles, carbon nanotubes, polymers. We used gold for our study. Now, why we selected gold among these several nanoparticles which were required? Because they have unique surface electronic optical properties that attract scientific interest in drug delivery, chemotherapy, chemical sensing. As of now, why cancer, they are being used in an enormous scale for cancer drug chemotherapy. And the basic pathophysiology being that is, they are supposed to, the absorption rate is 600 times more compared to a normal human cell. So they get accumulated into the cancer cell very easily as compared to a normal human cell. And these gold nanoparticles have been tried therapy in case of GI malignancies, especially pancreatic carcinomas. Now, what is the impact of gold nanoparticles? The reports show that these synthesized gold nanoparticles can circulate in the human body without being rejected by the immune response. But this behavior of these nanoparticles is based only on their small size, their shape and surface charges. So before this behavior is of concern. Why? Because during the synthesis of gold nanoparticles and their applications, we need to monitor these sizes regularly, because during the synthesis various sizes of shapes of gold nanoparticles will be synthesized, will definitely be a health hazard if they are not related to the size. Now, in contrast to the multitude of studies that address the clinical use of gold nanoparticles, as I mentioned earlier, only little is known about their potential toxicological effects, such as acute toxicity, induction of inflammatory response in embryos as well as in adult fish. Now, some of the studies say that the toxicity caused by gold nanoparticles could release of reactive oxygen species, or due to the release of cytokines causing release of inflammatory mediators, which could be hazard to the human body. Now, however, their toxicity due to nano size bioaccumulation is being rarely discussed. So it has been said that the studies of toxicity in the area of research is still limited. So especially knowledge about their size, charge, surface chemistry dependent in vivo toxicity is needed to predict the hazard potential of gold nanoparticles for humans. So this is an institute, that is CSIR, an Indian Institute of Toxicology Research, which is located in Lucknow in India. Now they have an enormous studies done on nanomaterials, and they have defined a certain standard parameters, like certain parameters which I have mentioned here. Now based on these standard parameters, I have included some of these parameters for my study. So we intend to study the nanoparticles associated systemic toxicity, because any shortcomings in this regard would definitely reflect in our next generation. So why among all the vertebrate models like rabbit or mouse, I selected, why zebrafish was selected, because it is said that being a small animal model, a variety of various advantages compared to other vertebrate model, because it first of all, why I selected vertebral model to study the study the gold nanoparticles effects on it, because it has it is similar to humans having. Second thing, it is of smaller size, and all major organs appears within 5 days of fertilization. It has got a short generation time of 3 to 4 months, and it has a good breeding capacity. It produces around 300 to 400 eggs every 2 weeks. Now, what were my aims of my study? Now, to study the effect of these gold nanoparticles causing systemic toxicity in zebrafish, that is including the organs like brain, testes, liver, heart, and assessment of these gold nanoparticles of size range 15 and 45 nanometers, evaluation in vivo toxicology, like during my course study, I'll let you know what we actually, how did we conduct the study. So aim was basically to assess the gold nanoparticles and to evaluate the bioaccumulation of these gold nanoparticles in the major organs of these fish, and to study the histopathological effects of gold nanoparticles on the major organs. So the materials and methods used in the study were, we used a total of 36 adult zebra fishes from the Central Research Laboratory belonging to the species of Danio reo, and they all belonged to the age group of around 3 to 4 months, weighing 0.5 grams with a size measuring 1.5 to 2 centimeters. So these fishes were kept in the laboratory 12 days prior to the study so that they get suitable to the environment, maintaining a light and dark cycle of 14 to 10 hours, temperature being 26 to 28.5 degrees centigrade, keeping a pH of 6.8 to 7.5, and feeding them twice daily. Now, these fishes, among all the 36 of healthy adult fishes, we divided into 3 groups of 12 fishes each, where pertaining to one group were given 15 nanometer size gold particles, the other 12 fishes were given 45 size gold nanoparticles, and other 12 fishes were kept as a control. Now these nanoparticles were given, gold nanoparticles were given at the concentration of 20 microgram, and they were fed for 28 days. So basically wanted to see the chronic study of effect of these nanoparticles on the major organs. So as I said earlier, these 36 were divided into 3 groups of 12 each, and they were subjected for ICP-MS technique, that is to study the bioaccumulation of the gold content, as well as they were subjected for histopathological sections. So before taking the size of 15 and 45, we need to characterize the size of 15 and 45 by 3 different methods like ultraviolet, transmission electron microscopy, and X-ray diffraction absorptiometry. This characterization is important because we need to confirm that the range of gold nanoparticles are within these size limits. So after selection of these 2 size gold nanoparticles, we subjected the fishes for we feeded the fishes with these nanoparticles for a 28-day study. So how was the feeding of zebra fish done was, a butterfly syringe was used which was attached to the micropipette, and this fish was held with a damp tissue to keep its skin moist, and the test solution was administered orally. So the study parameters were, as I said, the histopathological assessment of the cellular morphology in the major organs, and to quantify the gold which was fed to see the accumulation of these particles in their major organs by ICP-MS technique. So this was the first step by basically confirming that the nanoparticles were giving belong to this range group of 15 nanometer. Initially the nanoparticles were synthesized by sodium citrate solution, and then they were further characterized by UV spectroscopy, transmission electron microscopy, and X-ray diffractiometry. So after this characterization, when the site distribution plot was graphed, it was seen that the majority of the particles were belonging to the range of 10 to 15 nanometers, with average being of 15 nanometers. Similarly, it was done with 45 nanometers, and we see that the graph plotted here showed that the majority of the particles belong to 45 nanometers. Hence, these two nanoparticles among the range of 1 to 100 were considered in our study. Now, before subjecting the fishes for ICP-MS technique, we have certain preoperative requisites, like we need to dissect the fishes, expel the major organs from the fishes, we need to subject them for acid digestion by nitric acid, filter them, and then we had submitted for ICP-MS technique, that is inductive coupled plasma mass spectroscopy method. So the results obtained from the ICP-MS technique which proved that the majority of the gold were accumulated in the majority of the gold accumulated was seen in testis, followed by heart, followed by liver, followed by kidney and brain. So this was a graphical representation of the same thing which I mentioned here. So these were the major organs we dissected and sent for histopathological section. So the organs, this is the main pathological part. I am being a pathologist, my main interest was this area, that when I got the sections after the feeding of the gold nanoparticles as compared to the control slide of a zebra fish, I saw that in 15 nanometer there is a cytoplasmic vacuolation of the hepatocytes, with the nucleus being pycnotic and pushed to the eccentric. Whereas as compared to the control slide, the 45 nanometers fishes did not show much changes. They were good, nice hepatocytes with amphiphilic cytoplasm with a centrally placed nucleoli. The testis, this is a control slide of a testis which shows a nice seminiferous tubules with the immature, that is the primary and the secondary spermatocytes rimming the seminiferous tubule with a thickened basement membrane, and this is the spermatid that basically we can here see the spermatogenesis of a testis from the zebrafish. Now when we compare the control slide with a slide of 15 nanometer under under high power, we see that there is few detachment of these immature cells from the basement membrane, and this, when you compare the cell population, the spermatids are more in number as compared to the size of 45 nanometer. Here we see that the basement membrane is thickened as compared to the basement membrane which was thinned out in 15 nanometer, and there were more amount of immature cells here. So basically this was our observation we just noted in light microscopy, but the cell population studies should be proved actually by flow cytometry by advanced ancillary techniques. As when we compared the kidney slide from a control section, we noticed that slight changes were noted in DCT as compared to the PCT, where we see that there was slight dissociation of the cells from the basement membrane with few inflammatory infiltrate in the interstitium. Now for our knowledge, it's said that the hematopoiesis in the zebrafish occurs mainly in the kidney as compared to the humans, where it occurs in the spleen and bone marrow. Now in the heart, there were not much changes noted in the heart as compared to the control slide, but when we saw in 15 nanometer, there were minimal amount of extravasation of the RBCs in the myocardium, when no change was noted in 45 nanometer. It was just a mirror image of the control slide. This is a high power view showing the extravasation of RBCs in the myocardium, and this is a high power view which shows a completely similar image to that of the control. Section from the brain slide, when we compared the 15 nanometer slide, the section from the brain showed minimal amount of gliosis here at one foci, where there were no much changes noted in the brain tissue as compared to the control slide. So this was the results drawn after the histopathological sections, that the major changes were noted in the liver and the testis, where very minimal changes were noted in the myocardium as well as in the neural tissue and the kidney parenchyma. So the conclusions drawn from my study was the gold nanoparticles with an average diameter of 15 and size range 45 were successfully synthesized through chemical reduction method, and further proving the size was characterized by using UV spectrometer, TEM and X-ray diffractioabsorptiometry. Now in comparison with the control group, the chronic exposure of gold nanoparticles of both size range showed variations in the hepatic size-dependent alteration in the basal architecture of the testicular tissue, with little effects on the myocardium and neural tissue. So according to the pattern of bioaccumulation of the gold content, which was assessed by ICP-MS technique, we saw that the majority of the gold was accumulated in the testis, followed by the heart, followed by the liver, brain and kidney, with both size range 15 and 45 nanometer. So hence the conclusion drawn here, after seeing the results, we come to a conclusion that most of the toxicity or the cellular changes were noted in 15 nanometer as compared to a 45 nanometer. Hence it is said that these nanoparticles possess quantum effect on the size and duration of exposure. The histopathological changes suggest that the particles of 15 nanometer as compared to the 45 interact with the cellular proteins, causing major alterations in the major organs. So this is a key factor. Therefore, we say that in a lot of literature that the size-dependent toxicity matters. The smaller the size, the more is the toxicity level, which was significant with the study done by Abdelhelm and Gerard in 2011. We would, hence, our future plans depending upon the few histopathological changes during our experimental study, we need to do further advanced kinetic and toxikinetic studies the cell population of the spermatogenesis, and if there is any DNA damage or apoptosis by comet assays, flow cytometry, and further the ultrastructural analysis of bioaccumulation by transmission electron microscopy. We will be required to extend this existing knowledge on particle behavior causing toxicity in vivo. because it said that the in vivo toxicity models are quite better as compared to the in vitro because the results there are difficult to extrapolate. So these were my references taken for my study. Thank you.
clinical course, some patients, about 50% of them, will never receive therapy, they will not require therapy, and they will live normal lifespan without any therapy. However, people with high-risk factors such as unmutated IgDH, ZAP70 co-expression, and interface cytogenetics with loss of 17p with p53 gene or ATM with 11q23 loss, they will require therapy quite soon after initial diagnosis. And if not treated, they will die. And even on treatment with regular chemotherapy, with purine analogs and antibodies, often they will relapse and finally they will die. An average lifespan in high-risk group, even on therapy, is about 5 years. So it's in certain group of people, this is incurable disease unless bone marrow transplant is performed. Further, it is complicated by fact that this is disease of a rather older population of people which cannot tolerate chemotherapy very well. There is a very interesting property of CLL B cells. They have constitutively activated the B cell receptor signaling. Basically, these cells behave like they will be all the time stimulated by external signal. And as you can see on the schema of the BCR signaling, there is a well-recognized several targets which small molecules were developed which act as a very effective inhibitors. All these molecules were studied in a therapy of CLL with various results. Today we'll focus just on BTK. BTK represents very attractive target for therapy of CLL. It is a TEC family kinase. It leads to activation of PI3 kinase, PLC gamma, MAP kinase, and through all three of them to activation of NF-kappa B, which is quite. It also produces very nice phenotype. If you mutate it in a mice, you produce SID mice, which are B cells depleted. Naturally occurring mutation in humans are linked to X-linked agammaglobulinemia, and patients are characterized with complete loss of B cells and underproduction of IgG. Among many molecules which are potent inhibitors of BTK, one, ibrutinib, is very new. This is new in class because it is irreversible inhibitor of this protein. In general, in human therapy, as a targeted therapies, people are reluctant to use irreversible inhibitors because off-target effect of such inhibitors can be catastrophic. And this was the case with these molecules because alternative irreversible targets could be represented by all these possible kinases. So it was big fear that if we use it in therapeutic doses, one of these kinases will be inhibited and it will be, unpredictable side effects. However, since big group of patients treated with multiple drug therapies and multiple antibodies were desperate for some sort of treatment, otherwise this population of patients will be dead within another 6 months, FDA decided on a pivotal clinical study where 101 of these patients with at least 4 prior failed therapy were treated with 2 different doses, 420 or 840 milligram per dose QD, and the results of the study resulted with fast-track approval of this drug. We'll not talk today about treatment-naive patients, we'll talk just about desperate people which fail at least 4 therapies. Normally, half-life survival in these people which they will be treated with classical therapy will end at here at 12, no one will be alive. As you can see on this study, up to 42 months, and this is year-old slide, so nowadays up to 12 months addition to 42, which is 56, more than 80% of patients are still alive. Basically, it's revolutionized, this drug revolutionized the therapy for treatment-resistant relapsed CLL patients. However, you see that about 20% of them succumb to disease and they die. Patients, we see that some of them die from unrelated causes like infection because they are very immunosuppressed. but large population will suffer from Richter's transformation, which is basically transition of mature phenotype of CLL cells to diffuse large B-cell lymphoma, which is very rapidly fatal, and large group of patients will progress and break through therapy with regular CLL without transformation. So my group was interested in what are causes of suddenly patients which responded very well to therapy for on average a year, suddenly they become irresponsive to therapy. Here is overall survival of people with Richter's transformation, which is quite short, even with a very aggressive therapy, which is adjusted to diffuse large B-cell lymphomas. They don't do quite well, and progressive CLL patients don't do well either. What we discovered in the initial group of patients, that what happened is that majority of them will develop mutation in a binding site of ibrutinib. So the drug, instead of binding irreversibly to BTK, now binds with much less affinity, and it's reversible inhibitor. Therefore, capable to escape suppression. However, in subgroup of this patient, we found that BTK was intact, and when we look further, looking on a pathway, as you remember from the schema representing BCR signaling, next kinase under BTK influences PLC gamma, and we found that they develop mutations of PLC gamma. And when we studied this PLC gamma, when it was transfected to B cells, we discovered that basically this is hyperactive PLC gamma, which is independent of BTK inhibition. So you can have still persistent good inhibition of BTK. However, this mutation allows cells to escape this inhibition through downstream activation of PLC gamma. What is very interesting and what brings the hope to this patient is that if you discover their breakthrough resistance at this point, there is very few options. Usually they die within 6-7 months, and you have no opportunity to come up with alternative therapy. As you remember, most of them are resistant to classical therapies, so you need to assign them to studies, and majority of studies require a washout period to get rid of old drug before you start new drug. Therefore, there was very limited options for these patients. But what we did, since we have stored sample through the therapy for this patient, every 3 months tube of blood is procured and cells are isolated, we're able to track back from index patients, about 10 of them, samples, and what we discovered, what is quite representative of biological situation in this patient, that many months before clinical relapse, we were able to, with sensitive method, to discover mutations which eventually will lead to overgrowth of the clone. Basically, this clone with mutation will take over and will dominate their disease. So thinking was, if we can develop tests which with high sensitivity can identify early arrival of the new clone which is resistant, we'll have plenty of time to decide what alternative therapy use for this patient. So my group was tasked with the development of CLIA CEP-approved molecular tests to detect such small subsets, because they start literally with very few cells in patients with a low burden of disease. We chose ion torrent platform because our thinking is that we need to do this test frequently, considering population of patients which with CLL which is treated in our institution. We cannot batch samples. Clinicians want to know answer right away. And using Illumina platform will force us to be very wasteful, or to wait for a couple of weeks to accumulate enough patients to fill a line on the Illumina platform. This is very convenient, small box. As I mentioned before, it's affordable. Whole system setup costs $75,000 with software which helps you to decipher data. It's intimidating for people which never did molecular biology, but I think that any pathologist who went through basic training and passed the boards will be able to adopt to this technology. The chemistry is remarkably simple. We all learn about this process in high school. Synthesis of DNA generates release of hydrogen with attachment of every single base, A, T, G, C, based on a template. And one can only wonder why it was missed for such a long time that this phenomenon can use before sequencing. Of course, it was impossible before development of high production microprocessors, because how it is assessed now, you have the chip which has millions of little wells, and every well is fabricated to the point that it acts like a mini reactor. When you create your library, you attach your monoclonal amplified strand of DNA, which falls randomly to any of these addressable wells, which computers are monitoring all the time. The chip is the reaction chamber, which under control of computer is flooded with A, wash, T, wash, G, wash, C, wash. And it's done for several hundred times. Each time, if molecule will attach one or several A's, in time when A is in a platform, it will generate release of ions. Ions are measured by microprocessor pH sensing. Symbol will be sent to computer as an electric impulse, and computer will assign positive signal or negative signal. The Achilles heel of this platform is, you can imagine when you have long stretch of AAA, which will attach TTTT, machine get confused. After above 5 or 6, the same nucleotides, the system, therefore the height of the peak will not reflect how many homopolymers was added. But up to 4 is pretty accurate, and they are working on algorithm which will correct this overcall or undercall of homopolymers. So this is a workflow, really very simple. You have kit, which you prepare library. You start with 5 nanogram of DNA. You can start with a whole cell lysate without even isolation of DNA. You prepare your template. After you generate your library, you run your sequence, and the sequencer is hooked up through a variant caller to your software, which comes with the system. It makes the calls. Of course, you need to have some basic knowledge of how to read DNA sequence and how to apply QC criteria. But this is truly remarkable, straightforward. As a matter of fact, on several research projects in my lab, high school students which are interested in going to medical school are able to run experiments using this system, and they are quite successful, and they will be presenting papers during CAP meeting. It's so simple, so don't be intimidated by next generation sequencing. This is really off-the-box system which everyone can develop skills. Usually it takes for a lab about 5-6 months to get used to it. So we use a custom AmpliSeq approach because it was quite targeted. Basically, you send your sequence of interest to Life Technologies. They have algorithms which will develop your system of multiplex primers. They make sure that primers will not interact with each other. So it's very stringent. So for some genes, they will send you back your product, and they will say, this segment cannot be measured because we have too many interactions. Or they will say it can be measured only if we provide you with primers in 4 or 6 pools, which make it so expensive that it's not practical. But for general use, they usually send you 1 or 2 or 3 pools, which is, if you compare to number of reactions and number of information, how much you will gain from such assay, not very expensive. Of course, to avoid any surprises, we did very extensive in silico work, where you get theoretical primer pairs, you analyze them versus your targeted sequence, and you know, should you order your primers or you should work some more on it. This is our general CLL panel, which contains all these genes which are important in CLL, and we use it routinely in CLL prediction. However, since we are asked to focus on BTK and PLC gamma, we basically remove it from this panel and we did sub-panel. As you can see, majority of genes are covered in 100%, and missing nucleotides are mostly in intron, because sometimes when you develop primers, you develop them with padding from introns to make sure that you are covering the entire exonic sequence. What is important to realize that often in CLL patients which are successfully treated with such therapies, number of your B cells is very low. If you try to isolate DNA from just normal mononuclear cells or all leukocytes in such blood sample, and you have just 0.5% of CLL cells, of course you will get falsely negative results, because majority of DNA is coming from other leukocytes, not your malignant leukemic cells. Therefore, from beginning, we choose strategy where we will use DNA isolated from purified B cells, which we purify using magnetic paramagnetic beads. It's markedly improved sensitivity of the assay. After we did pre-validation in a research lab, then test was sent to CLIA approved lab, where they use clinical sample with high allelic burden to make dilutional studies. They also use cell lines which are existent with BTK mutation, not so much with PLC gamma. And of course, all recommended studies of precision, reproducibility, and analytical sensitivities were performed. Using this approach and being very conservative, we established that sensitivity of this method on B-cell purified DNA is 5% of allelic variant load for both BTK and PLC gamma. Also, we observe very often 2%, which then with progression of disease will progress to 5%, 20, which clearly indicates that even a low percent you can detect it. But because of CLIA regulations, we kept it at 5% because this was most reliable. There was no evidence of strain bias or GC rich region bias, which is very important. Here is characterization of our panel. For BTK and PLC gamma, we have 87 amplicon panel covering 100% of coding sequences of both genes. Uniformity of target base coverage was 99.3%. of base reads on target was 99.4. Amplicon with no strand bias was 99%. Amplicons reading end-to-end was 96%. Important when you are looking for sensitive assay to not miss any minor allelic variant was that the reads of amplicons with at least 500 reads was 100%, which is standard in a clinical CAP approved labs, but truly average depth of reads on target amplicons was 13,800, and there was no GC region bias observed. This is example of representative BTK coverage per amplicon, and as you can see, the lowest coverage is 7,000 deep, which is very solid, and it's a no strand bias in this. And here is PLC gamma, which average coverage of more than 3,000 in the lowest amplicon, and the rest of it is really very deep. So in conclusion, clinically validated BTK PLC gamma NGS assay has analytical sensitivity of 5%, variant allele frequency, and allows early detection of emerging subclones in patients continuously treated with ibrutinib. This is very important from clinical point of view because it affords you a quite long period of time to reset what patient is treated with. So this patient, before, when it was discovered at the point of clinical relapse, it was too late. Everyone was in panic, and many of these patients will suffer consequences of breakthrough and they will die. Now, with all these new kinase inhibitors emerging, we have enough time to switch them, wash away period for ibrutinib, and we are switching them now to alternative BTK kinase inhibitors or different kinase inhibitors. So it's very helpful for patients with CLL, and the impact of this intervention will be studied in several clinical studies, but my expectation is that it really will change the landscape of patients which break through while on ibrutinib. I of course wish to help, thank all the patients which were willing to participate in the studies, because without their consent, without their willingness to. And our team of clinicians from Ohio State, which is led by Dr. John Bird, faculty in laboratory which help with the accumulation of clinical data, and big team of technicians who help us to develop this test. Thank you much, and I will take any questions. Yeah, it occurs in a, we developed this test to cover entire genes because it was also, we will take advantage of the samples to look for emergence of other mutations. However, in BTK is reproducibly at a site which binds ibrutinib at 481, which normally is serine. And right now we discover about 12 different variants, and it basically changes the non-polar amino acid to polar amino acids and kicks out ibrutinib. And for PLC gamma, there are two hot spots, most often in 648. There is another one at 652, which presumably also is hyperactive. When we studied 648 in a transfection experiment, and we proved that it makes cells independent of BTK activity, the other one is not studied yet. Yeah, it's possible to develop just, first of all, it will be cheaper, because if we just focus on these two hotspots, we can, instead of running 10 patients by 318 chip, we could probably put 20 patients. But since we are still conducting research, we are not so eager to decide that those are only two causative mutations. As I mentioned before, and I didn't have time, we developed very comprehensive panel for all these possible other targets of ibrutinib, and we found no evidence of a selective mutation, because we assume that mutation happened through regular evolutionary mechanism among CLL cells. When you are under pressure from ibrutinib, which irreversibly inhibits your BTK, suddenly one cell which develops this advantageous mutation escapes, just like elephant with long trunk versus short trunk. When there was advantage, he persisted. So, thank you.
It's working. This is working.
It's working. Oh, great. I just need to
Okay.
Hello.
Hi. Hi, how are you?
You're going to, yeah. Okay, like, afterwards I would like to see how the pictures on my presentation will look like, so we can change the brightness.
So,
no.
What would I do? Should I put it on the desktop? Should I put it?
This
Mine
is the,
I'll do it. So that's the final would be?
Yeah.
Mine's not in there. He just uploaded.
You can put it in. You have it on a pen drive?
It was there.
No, she was using.
It was.
You must go back.
Okay, then never mind if it's outside.
Yes.
That one's mine. The final,
just double
final.
click.
This one?
Final one.
Final one? Should I do it?
Yes, just double click.
So just do that when after you need to check your.
Just a little.
Okay.
Actually, even I haven't had a look at mine. You have it?
It's very quick. Nice.
I'm Sujata.
I'm Sujata. Nice to meet you.
Andrea.
Okay.
Nice to meet you.
So you want to get yours loaded up so it's ready?
Yes.
Just checking it out.
I'm just deleting some slides, or else it will be too.
Yeah. That's okay.
Where is delete?
Delete.
This is different from my backspace. Okay. Yes. Just this. Thank you. Thank you.
Just one you deleted. Just the one with this. Just loaded it and open it. Okay, that's all right. And it go.
So just. Double click or open. Yes. And then I guess it's right here. I'm not sure how to make it go to the full screen. This one. This. I think, when is your call? Yeah, so you would be right after me, so yeah.
Actually, I also want to my presentation is there, but I want to replace, it was not final.
Can I just
get me out? This? Yeah, so you can put it, yeah.
Just recognizing this.
Do you think it got? So would you go to computer and look for the?
Well, I'm trying to go to computer here, but it just said.
There was a young man helping. He stepped out.
But he will come.
Okay. Where's the computer?
Can you go to this corner?
Music, video. So are they running a little late? Is it what is happening?
It's a break until 3:25, so we're kind of on time.
Cannot find how they how to read the.
Do you think that is?
Yeah, it is.
How about if so we click on this?
Yeah, that's what I
Nothing
did first.
comes.
Oh, right here.
Yeah.
Okay. And then.
Yeah, I saw it.
This is DVD.
I think I saw it. Maybe we go back where you were, and one more. Is that a flash drive?
Okay.
Is it Kodak?
No, it's not. Really?
We're having trouble loading her. She has her talk on her flash drive.
Okay.
But we're having trouble finding it on the computer.
So, this is your flash drive, correct?
This one.
This.
Which one?
So, we are day 2.
But we cannot first find.
Yeah,
we need to
she's
find
just-
this.
It's on her flash drive.
Oh.
We need to find that.
So would it be this?
No, that's DVD.
You know what? One of these is not active. Try. Can you try the other one?
Okay.
And I never know which is active.
Okay, now. Okay.
Yeah.
Okay.
Okay.
I see. Okay.
You fixed it.
Yeah. So just after the lady finishes, use that port because the other one is inactive.
is giving multiple options. What's happening? It is giving these multiple options. I'm just Sure. Yes, please. So it is giving these, like I'm trying to look it up and
outside.
What?
Just
Yeah.
outside. You were trying to put it in
Yeah,
presentation mode?
Yes. Yeah. Okay.
Or F5.
Okay.
So
It looks
yours on
good.
your hardware is
No,
on
I just put on
desktop.
the desktop. So we can minimize it.
The buttons are weird. I don't know how to do them.
Okay. So that one. So which ones is yours?
Yeah, I don't know.
Yours is in some of these?
Day 2. Did you put yours?
Mine, I put on the outside.
Okay, and then...
He loaded mine today, just this morning.
Okay, so let's look at it. Is
Yeah,
any
yeah,
of
on the
these?
final.
Let's say
Yes.
track 7.
Final.
Oh, okay, yeah, okay.
Okay.
How do you pronounce your first name?
Aisha.
Aisha? Okay, because I think I may introduce you next.
Oh, is it what we are doing? We are
Well, I'm
introducing.
first and then you're next. I'm supposed to be up there.
Oh, I
so
see.
I talk and then
I see.
she's going to help me.
Okay.
Yeah, and then I'll introduce you.
The other moderator left, so it's just the two of us.
Okay. Okay. Nice meeting you.
I'm Gabriela Otra.
Okay. Where are you from?
Emory.
Oh, great. Great. So you work with Volkan outside.
Dr. Atze, yeah.
Yes.
He's a planet by itself and he's doing wonderful things.
He
Yeah,
is very busy.
he's GI. I don't do that much GI. I do
Well, what do
mostly
you do?
breast. And
You do breast? I do breast too.
oh, okay, let's speak about it.
Yeah.
I
You did?
a long time ago, way before Vulcan.
Dr. Sewell.
Yes, he was there.
And he's
Oh,
still...
Shoba, Sharma.
She left Emory 2 years ago.
And I know Alyssa.
Dr.
Simpson.
Tessis, yeah, she does a lot of GI.
Yeah,
But maybe Melinda Lewis.
She was there when I was president. So is she still there?
Yeah, actually I was, I did fellowship at Emory in psychopathology when she was still living at the program.
And Marlena Musinka.
Yeah, actually, yeah. I do most of my sign-up activities. So my
Marina, I saw.
Yeah.
Because we were residents together.
Oh, okay.
And so my daughter and their son, they used to play a little bit.
I naturally
He was very
still speak to him, but he's so handsome.
he's a big.
Yeah, and he finished now, I think. Finished in New York.
I want to see my
Okay.
which port is
Interesting.
This port is working, the front one. Not
It goes so
Yeah, that one.
Fast, but you can see.
It is there one, but it is not final. Final is this one. So I want to
every
this one.
Okay. So,
This is I think the new one.
So maybe this year.
but there's nothing on that. Oh, okay. So, is this the one?
Yeah.
Okay, so then get that and put here.
Or I can come with this at the 10.
Okay. Hello? Yeah.
I want to replace my presentation. This is the new one.
So Dr. Guy.
Yeah.
You're going to want to use that one.
This one.
And this one here is the last presenters.
Then you are here.
This isn't yours,
This is
right?
for the next one. This
I'll just minimize that. We're gonna put it in this file, okay? It's gonna sit right
In
here.
your file also, my name was there, so I wanted to replace it. This one, no, this is old. I want to
So,
replace it.
Okay,
I'm going
no
to
problem.
make a mark here.
All right, I'm gonna delete this one. Which one is it again, sir?
Yeah.
Rough?
Okay. I'm trying to get everybody that.
We're not switching back?
No.
Okay, and then final rate?
Should be okay to do it, she just needs to leave without
We have another one that's final.
final session for the certificate. But we'll do that.
Is it good? And just, you got your microphone here too.
I think we should do after everyone now, just in case. Yeah. Yeah, we'll do it. Until somebody changes.
Have you been involved with this conference before?
Last year I was here and I moderated.
You did, so mine is in this folder. It should be in the other folder. Is this? Oh, I'm not sure. What do you need? You could put yours on the desktop.
I'm here.
Could you put mine? You want to put mine?
This one here?
Yeah, the final.
Okay, the final. Oh, it's open. Okay. Can I close it?
Yeah.
No, here, yours.
It's so
The final, this one. No, this is one. Is yours. Okay.
Yeah, that one.
Okay. And this is it.
Oh yeah.
Now it comes.
Yeah, you're
okay.
good.
I'm gonna do the same for mine.
It's just easier, I think.
Just rename it.
It's quite an eclectic approach. I mean, you have everything from pathology to next-gen sequencing to computer-aided things. It's just like, I feel that it's opening my mind.
I think I have to leave right before your talk, and I'm so sorry. I have to catch a plane. So I'm so sorry to miss
at all.
A colleague of mine said, would you like to go
surrounding cells are cells of distant tissues. The hedgehog ligands are released as membrane-bound particles with features of exosomes. So the person I collaborate with is Dr. Anna Mae Deal at Duke, and she has shown that the hedgehog ligands are produced and orchestrate regeneration and repair in many different types of liver diseases. Some of her original studies were in primary biliary cirrhosis. She's also shown activation in viral hepatitis and alcoholic hepatitis. Work from her lab has demonstrated that in the setting of liver injury, many different cell types can release hedgehog ligand. For example, inflammatory cells, the hepatic stellate cells, which are myofibroblastic type cells, can release hedgehog, endothelial cells, cholangiocytes. I think our pointer's dying. But predominantly, the largest producer of hedgehog ligand is an injured hepatocyte. What types of injury can cause this? Basically, apoptosis, endoplasmic reticulum stress, lipotoxic stress, any type of stress that the hepatocyte is signaling present in non-alcoholic steatohepatitis. Since ballooning is one for the diagnosis of NASH, and here are some normal hepatocytes with inflammation, and here in the cleared out changes are ballooned hepatocytes. So ballooning is a major histologic to make the diagnosis of NASH, and ballooning is associated with fibrosis. We wanted to find out, do ballooned hepatocytes produce hedgehog ligand? And if so, can this propagate the fibrogenesis of NASH? We used 90 adult liver biopsies from the NASH Clinical Research Network. So it's very well characterized cohort of NASH. We determined, is there increased hedgehog activity by showing, are there increased numbers of hedgehog producing cells, and are there increased numbers of hedgehog responsive cells, meaning cells that are GLE2 positive. We found that hedgehog pathway activity was strongly correlated with the ballooning grade and the fibrosis stage in NASH. It was also correlated with other markers of liver repair, including the number of progenitors and myofibroblastic cells. And not only just the histologic parameters, but also the hedgehog pathway activity that was increased correlated with many clinical parameters that are associated with advanced NASH, such as older patient age, higher BMI, insulin resistance, hypertension. And to show you some photos of this, these panels show NASH in a low stage and high stage, 0 to S4. We used immunohistochemistry to stain for sonic hedgehog using a brown chromogen. And as you can see, as the fibrosis stage increases, there's a dramatic increase in the expression of sonic hedgehog coming from the injured hepatocytes. And the graph is shown on the bottom. In steatohepatitis, we grade how much ballooning is grade 0 to 3. The least with the ballooning grade. So from a low stage to a high stage, there's more fibrosis, there's more inflammation, and there's more of a ductular reaction. This micrograph shows that GLE2, or hedgehog responsiveness, we used a brown chromogen to highlight that. And as the fibrosis stage increases, we have increased hedgehog responsive cells. As the portal inflammation grade increases, we have increased number of hedgehog responsive cells. This part of the study, we used co-staining
for progenitors and hedgehog responsiveness. So hepatic progenitors are keratin 7 positive. We used a blue to show that. The pointer is keratin 7 is tagged with a blue chromogen. GLI2 positivity is tagged with a brown chromogen. And you can see as the stage of fibrosis increases in NASH, there's increased progenitor populations that are hedgehog responsive. These stressed hepatocytes or ballooned hepatocytes release hedgehog ligand. Hedgehog ligand binds to the neighboring hedgehog responsive cells, and in this case, it was activated myofibroblasts and progenitors. Of this pathway promotes fibrogenesis in NASH. So our obvious, and this kind of sums up what we found, is that hepatocellular stress releases hedgehog, which signals to progenitors to proliferate, giving reduction, and it also turns quiescent hepatic stellate cells into myofibroblastic hepatic cells, laying down the collagenous matrix. So the next obvious question was, okay, so when you have regular old NASH, the hedgehog pathway comes on, and we think this, so if injury, could we turn off hedgehog? And so the same NIH-sponsored NASH Clinical Research Network did a clinical trial recently called the Pibbins trial. Is anybody familiar with Pibbins? If you're not a liver pathologist, you might not be. So in the Pibbins trial, they were seeking a therapy for NASH, and they found that giving therapeutic levels of vitamin E could reduce the amount of ballooning and reduce the histologic features of injury. So our question was, does vitamin E therapy turn hedgehog off? And we again used patients from the NIDDK-sponsored NASH CRN in the pretreatment group of human liver biopsies. You can see on the upper left post-treatment vitamin E responder groups, the amount of hedgehog production was that these were using, which is shown on the bottom panel. Likewise, we showed that the pre-treatment and post-treatment samples were different with regards to the amount of fibrosis and the amount of progenitors. Again, we used GLI2 to tag cells that are hedgehog responsive. And here we've used a triple immunohistochemical stain. Brown is tagged the activated myofibroblasts. Blue is tagging progenitors, SOX marker for hepatic progenitors. Blue is in red. So in the pre-treatment NASH samples, there's abundant fibrosis and progenitor activation. In the post, those that responded to vitamin E therapy, there was a dramatic reduction in the number of hedgehog responsive cells. So in summary, the hedgehog pathway is upregulated during NASH. Ballooning is the site of hedgehog production, and upregulation of hedgehog pathway and paracrine signaling promotes myofibroblast activation, the ductular reaction of progressive fibrosis. Hedgehog pathway was turned off with successful vitamin E therapy. And finally, to link obesity and NASH and hepatocellular carcinoma together, we looked at hedgehog signaling in hepatocellular carcinoma. And as you know, the incidence of HCC is increasing. It's a very deadly cancer, it often arises out of a background of fibrosis and cirrhosis, and a better understanding of the carcinogenesis of hepatocellular carcinoma is needed. So is anybody in the room familiar with the Warburg effect with regards to cancer cells? So one or two people, three. So basically in the 1920s, Otto Warburg discovered that cancer cells metabolize glucose differently from normal cells. Cancer cells utilize aerobic glycolysis, whereby the normal cells usually use mitochondrial oxidative phosphorylation. And this gives cancer cells an advantage for the generation of biomass to sustain proliferative activity of the rapidly dividing cells. And the bottom line is that aerobic glycolysis produces lactate. Lactate production provides a selective advantage to cancer cells over normal cells. In a previous animal model of hepatocellular carcinoma, we showed that blocking hedgehog activity caused the tumor mass to involute, and it also caused myofibroblast loss and fibrosis regression. So our question was, does hedgehog pathway signaling influence metabolism of HCC cells via the Warburg effect? And in the top panel, you can see that there's human hepatocellular carcinoma. In the upper left corner of A, you can see that the tumor is strongly positive for sonic hedgehog, and the non-tumor has less sonic hedgehog. And the little inset on the left is to remind us what a stellate cell is and where it resides. Stellate cell is shown there in blue, and it resides in the space of Dease between the hepatocytes and the sinusoidal endothelial line. In this, in human HCC cancer model, we found that in panel B, you can see the tumor cells are not staining for hedgehog. Here we've stained for GLI2 that are tagging the myofibroblasts that are surrounding the tumor nodules. In the lower panel D, you can see that the tumor mass is not undergoing glycolysis. Here we've stained for myofibroblasts and PKM2, which is a measure of glycolysis. So the Warburg effect was supposed to be that the tumor cells are undergoing glycolysis. And what we found was that the myofibroblasts surrounding the tumor cells are undergoing glycolysis. And that those myofibroblasts are hedgehog responsive. So basically what we found in hepatocellular carcinoma is the reverse Warburg effect, where cancer cells and stroma we know are interacting. In this instance, the stroma is undergoing glycolysis, producing lactate, and the cancer cells are using that as their energy source. And that all of that can be blocked if we block hedgehog. So in summary, in hepatocellular carcinoma, the tumor cells produce hedgehog ligand, stimulating the adjacent myofibroblasts to undergo glycolysis. The lactate is transported back to the tumor cells. This is the reverse Warburg effect and is regulated by hedgehog. So in conclusion, obesity and metabolic syndrome are linked to NASH and HCC, and hedgehog plays a vital role in the progression of NASH and in hepatocellular carcinogenesis. And so we think that potential therapies that could block the hedgehog signaling could be used to target therapies for NASH and HCC, and also this could be useful in the diagnosis of NASH and HCC. I want to thank the people in our lab, Dr. Anna Deal, Ayako Suzuki. There's a whole team of us working together to do these papers. That's it, thank you.
Changes in NASH are very heterogeneous across the liver. Was it reflected with heterogeneous intensity of staining for hedgehog and the effect of hedgehog was B1? Could you comment on that?
Yeah, so we used in the first paper, we had 90 different human samples, and we had the entire core biopsy. And we quantitated on high power field all along the biopsy. So we looked at every single high power field, and we quantitated the amount of hedgehog expression, and then correlated that to the pathology committee. It was a consensus committee that scored the fibrosis and ballooning. So things were independent of the committee, and I was blinded to those results by looking at the entire biopsies. Yeah, that's something that we really want to look at, because hepatocellular carcinoma is very heterogeneous. And in this paper, we used 5 human samples, not a large sample. So I would like to go back and see if maybe the hedgehog expression varies with the grade of cancer. And also I'm wondering if it could be a diagnostic marker as far as the glycolysis that gets turned on inside the cancer. Well, so it depends on how you look at it. The normal liver does not have hedgehog expression, very, very minimal. And for many years, people didn't believe that the hedgehog pathway was active in liver disease. And Dr. Deal has really brought this to the forefront. And in a normal liver, the hedgehog pathway is not active, but in various disease states, it gets turned on. So we think that it's a result of the injury that the pathway gets activated. And it's actually trying to fix it itself, but it's deregulated and causes the scarring.
On the same line of question, if you injure liver surgically, for example, take a scar from someone donated blood of his liver for transplant, do you have opportunity to observe similar changes, or if someone tries to kill himself with an overdose of acetaminophen? So it's acute liver injury, but it's not linked to metabolic syndrome.
Yes, in all different types of liver disease, this pathway has shown to be deregulated. We've done like partial hepatectomies. I'm not exactly sure about liver toxicity, but we think that it's kind of a generic pathway that's malfunctioning.
So basically, like any movement, because hedgehog is also used to just cut the skin or cut the nerves system.
Correct. Yeah.
I have a question too. Do you think that if you don't look at NASH syndromes, you'd see the same hedgehog upregulation in viral hepatitis, I mean BRC and
yeah, we haven't specific, like, isn't typically believed. But yes, there are, have looked at viral hepatitis C, hepatitis B, and the pathway is turned on. And again, it's regulating the fibrosis and those progenitors.
So that the ballooning is basically a phenotypic expression of the regulation, but the regulation may happen even in the absence of.
In other types of injury, it could get turned on and secreted from the Do we have another pointer? Like this one sometimes works, but it sometimes goes out. There's 2 up here. So I think we're ready for the next one.
Okay, should I just offer you this and maybe 2? Just for this very interesting.
Where is the pointer? Ladies and gentlemen, we switch from liver pathology to breast pathology, and we are going to talk about the evaluation of breast specimens after neoadjuvant chemotherapy. Neoadjuvant chemotherapy is defined as systemic chemotherapy giving prior to definitive surgery. For the last decade, neoadjuvant chemotherapy became a standard of care for many different tumors, including breast cancer. In purpose of applying chemotherapy, staging of large inoperable breast cancers, which permit the surgical resection, and it also is now the standard of care with high-risk disease who would require adjuvant chemotherapy and based on biological and tumor characteristics. And another important aspect of neoadjuvant chemotherapy is that it allows the ability to monitor treatment response, and we can tailor the subsequent local, regional, and systemic therapy based on the response of the patient. So this really is a very good model for individualized patient care. Evaluation of treatment responses to new agents is also used in setting. The studies using the adjuvant chemotherapy for many solid tumors, including breast carcinoma, requires large number of patients, but neoadjuvant chemotherapy provides a good window of opportunity to evaluate if a specific drug is effective or not. One very important aspect of neoadjuvant chemotherapy is that we should have a pre-treatment core needle biopsy, which should be adequate for one, unequivocally definitive for diagnosis of invasive carcinoma. Not only for carcinoma, but stromal invasion should be clearly established on core needle biopsy. And then the tissue should be adequate for assessment of prognostic and predictive factors. And in breast carcinoma, these factors include histologic grade and type, ERPR and HER2 status, and if there are other biomarkers such as Ki67, the tissue should be available for that. And for each patient, before they receive neoadjuvant chemotherapy, routinely axillary lymph node ultrasound should be evaluated. If the ultrasound is suspicious for metastatic disease, these lymph nodes should be FNA'd to establish the positive or negative nature of these lymph nodes. So the establishment of extent of the disease, stage of the disease prior to neoadjuvant chemotherapy is essential. And one most important critical step of specimen or specimens after neoadjuvant chemotherapy is the gross assessment of the specimen. It's not only that we look at the specimen, but how well we sample the material, and where we sample is very important, and I would like to show you some examples. It is very important that when we evaluate the specimens after neoadjuvant chemotherapy, we should have access to imaging findings not only prior to neoadjuvant chemotherapy, but also during the chemotherapy. So before we evaluate specimens, we should definitely know the most recent findings of either ultrasound or MRI scans. I would like to give you an example. This is a 30-year-old female presented with a 2.5 centimeter palpable breast mass, and she had a physical examination revealing a palpable prominent axillary lymph node. She had a core biopsy of the breast and a fine needle aspiration of the lymph node, and her breast core needle biopsy showed invasive ductal carcinoma, and the axillary lymph node was positive for metastatic carcinoma. So based on this finding, her clinical stage is stage 3, and her expected survival is around 40%. So patient receives neoadjuvant chemotherapy, and clinically the tumor becomes softer and smaller. Lymph nodes were no longer palpable, so she had a good response in both her breast and axillary lymph nodes. She had an MRI right before her surgery, which showed complete resolution of the mass, and she underwent an excision of the mass and complete axillary section. Her MRI scans, this is her initial tumor, and there was another nodule which under the ultrasound and MRI appearance, the radiologist thought it was a fibroadenoma, and this was also FNA and was confirmed that this lesion is fibroadenoma, and this lesion is invasive carcinoma. And this is her same MRI scan after neoadjuvant chemotherapy. As you can see that the tumor completely resolved and the fibrosis is staying the same. So with this, she underwent only a segmental resection, removing this area of the tumor, and this is her segmental resection, which is serialless sectioned. And this is her biopsy clip, which was put under the ultrasound evaluation when they did the initial biopsy of the breast cancer. And here is the fibroadenoma. And we sample the entire tumor bed, which is defined as the fibrous area around the clip, and there was no residual carcinoma. Here is the clip, and then the entire area is fibrous for histologic evaluation, and there was no residual invasive carcinoma identified. Since she had an originally positive lymph node, went a complete axillary lymph node dissection. All her lymph nodes were negative for metastatic carcinoma. These are sections of her breast showing that diffuse fibrosis with some histiocytic infiltrate, but no residual carcinoma. So with that, now she is T0, there is no residual carcinoma, so her expected survival is over 90%. So good prognostic, good response to chemotherapy is the best predictor in these patients who are receiving neoadjuvant chemotherapy. So determination of how well the tumor responds to chemotherapy is very important. As pathologists, we really help a lot to classify these patients if they are in the good prognostic category or they have a poor chemotherapy has become the standard therapy for locally advanced breast carcinoma. In terms of determination, who is going to respond to chemotherapy? What tools? We have quite sensitive imaging methods such as MRI is as project evaluation. Both clinical and imaging
responses can be accurate up to 80% of the patients, but there are certain types of breast cancer that can be imprecise. Both imaging and clinical methods can be both false positive and it can be also false negative. So histopathologic evaluation is the gold standard. In terms of defining pathologic responses, complete pathologic response is defined as complete absence of invasive carcinoma in breast and no residual metastatic carcinoma in the lymph node. This definition is very important because the studies and you study in the United States, the world, different studies pathologic response differently in the calculation. In MD Anderson, since we started neoadjuvant chemotherapy, we always include the lymph nodes in the pathologic response. And some studies include presence of ductal carcinoma in situ in the definition. In MD Anderson and many current acceptable grading systems now do not include residual in situ carcinoma. So right now, most commonly used systems, the no residual carcinoma, invasive carcinoma in the breast, and no metastatic carcinoma in the lymph node. Depending on the histologic and molecular type of breast carcinoma and the type of treatment the patient receives, pathologic complete response occurs up to 30% of the patients. So 2/3 of the patients, there is some residual carcinoma. And how do we classify that is quite controversial. Of course, if it's a complete response, it's a wonderful news and everybody is very happy. But then you have some response, but not complete disappearance of the tumor. How do we classify that it is the neoadjuvant chemotherapy? Sometimes the tumor shrinks like a concentric fashion like this, which is a very good thing, because if this is the entire tumor bed, the tumor shrinks like a balloon, then you can measure that by both clinically and imaging and histologically. It's an easy thing to measure. But a lot of the time what happens is that there are clusters of tumor, we call it scattered pattern, as you can see here. The entire tumor area was big, the same area stays still the same, but then instead of having a single tumor nidus, there are multiple foci of tumor. So what is the measurement of this tumor? Are we going to somehow add these foci together or measure the entire area? What is the exact tumor size? It's kind of controversial. And especially when you look at the 7th edition, which is the most recent edition of the AJCC system, which I disagree with their assessment, says that the largest contiguous area of the tumors, like this is the area, should be given. And this really is not a very accurate assessment, because in the same area, you may have a tumor cellularity of 5% versus you may have a tumor cellularity of 90%. So because of that, this is a little misleading to give the same tumor size for a tumor with 5% cellularity versus 90% cellularity is misleading. And it's very important to remember that nodal status after neoadjuvant chemotherapy still is the most important prognostic parameter. So we should do a careful lymph node dissection after chemotherapy. Changes that can occur in the breast, such as fibrosis, histiocytic reaction, can occur in the lymph nodes. And lymphoid depletion is a very common finding after neoadjuvant chemotherapy. Because of that, it's very difficult to identify the lymph nodes. So you have to do extra careful gross evaluation to find lymph nodes. As I said, in the United States there are different groups, predominantly medical oncology groups, evaluate the neoadjuvant chemotherapy, and in each group the definition is different. So the NSABP protocols do not count the lymph nodes. They only look at the primary breast tumor as the endpoint after chemotherapy. The other very commonly used system to grade the pathologic response is very commonly used in European countries is the Miller-Payne system. Again, the lymph nodes are not counted, only the breast is evaluated, and this system grade response in one. Grade 5 is complete pathology, no residual invasive carcinoma, and grade 1 is no reduction in overall cellularity, so no response, and then in between 2 to 4. So 4 90% cellularity. Look at the outcomes of these patients. One point is that grade 4, meaning that 90% tumor cell reduction. So it's very close to a complete response, but not complete response. The prognosis drops significantly, meaning that even identification of small foci of invasive carcinoma makes prognosis significantly lower compared to complete response. So based on this, it is our job to make sure that we do a careful evaluation and identify small foci of residual invasive carcinoma. In MD Anderson, we use this system called residual cancer burden, which includes evaluation of primary tumor, and we measure the primary tumor in 2 dimensions. And then we also evaluate the tumor cellularity, and we also look at the lymph node metastasis and size of the largest lymph node metastasis. So based on these 4 parameters, we came up with a system. Is in our website. If you go to mdanderson.org website and you put residual cancer burden, it is available freely, and we put the primary tumor bed size, and then the tumor cellularity, number of lymph nodes, and size of the largest lymph node metastasis, and then that nomogram gives you residual cancer burden 3. 3 is the minimal or no, it's the same, and the RCB 0 is complete. So in multiple different cohorts, we have shown that regardless of the type of neoadjuvant chemotherapy and regardless of the molecular subtyping of breast cancer, this grading system in residual cancer burden segregates the patients into different prognostic categories. So what do we look in the pathologic examination of specimens after neoadjuvant chemotherapy? We look at the residual tumor pattern, tumor size, and all the prognostic parameters important in patients without chemotherapy are also prognostic in these patients. So presence of lymphovascular invasion, lymph node status. Histologic type and grade is responses. We usually assign these cases as invasive carcinoma with therapy effect, and we rely on the histologic type and grade on the corneal biopsy. Identification of the tumor in order to evaluate the cellularity and in order to evaluate the size, it's essential and can be very difficult if you are not familiar with the imaging findings. So it requires thorough evaluation and it requires collaboration with imaging. So if you have a tumor like this after chemotherapy, here there is extensive necrosis, we would measure this entire tumor because this is a grossly, very easily identifiable tumor. So we would measure this tumor grossly and then put representative sections and assess the tumor cellularity. Another tumor which is quite distinct, so we can measure this tumor in 2 dimensions grossly, and that would be our tumor bed. But if you have cases like this where you have a little fibrous area which both on base gross appearance and palpation, you are not comfortable if it is the tumor bed or not, and it's very difficult to evaluate these cases based on gross evaluation only. So we go with specimen X-rays. And as I said, the placement of the clip prior to therapy is extremely important. And we look at where the clip is. We do the specimen X-ray. We identify the clip. And based on the patient's imaging features, we assess. I am underlining that word assess. We are not really actually measuring because we don't know where to measure, and the tumor bed. So we utilize our specimen X-rays extensively, and based on the appearance of the tumor bed, we determine how many sections that we are going to take. If this fibrotic area grossly looks completely fibrotic, we do not feel that there is a tumor, we may put 1 or 2 sections per centimeter of that fibrotic area, and if we do not identify any residual tumor, we may come back and put additional sections. And please remember that that Miller-Payne system, grading system, identification of small foci makes a major difference. So we would go back to the specimens and put additional. Sometimes you would this, which we would say like more than 80–90%. And then you may have areas a lot more fibrotic. So when we look at our sections, you know, we would say that this is a cellular area, this is more fibrotic area, and then we take the average to calculate the cancer tumor burden. In the adjacent breast parenchyma, there are histologic changes, and it's very important to be familiar with these histologic changes, not to confuse them with residual carcinoma. Similar histologic changes can also occur in lymph node metastases, histiocytic reaction, and sometimes to identify a small foci of residual metastatic carcinoma can be difficult, and we may utilize cytokeratins for that. Again, number of lymph nodes, positive lymph nodes is very important. We have to do careful evaluation. And even the small clusters are significant. We would count them as a positive lymph node. So we do not use the ITC terminology, isolated tumor cells terminology, after neoadjuvant chemotherapy. In summary, neoadjuvant chemotherapy is being used more frequently now, and pathologic response is an important predictor of survival. Complete pathologic response provide the best prognosis, but as pathologists, it's our role to thoroughly evaluate the specimen to conclude that that's a complete pathologic response. and we should be familiar with the chemotherapy-induced changes in non-neoplastic tissue, not to mistaking for residual tumor or the residual tumor non-neoplastic cells, because sometimes, especially low-grade carcinomas, can be so hypocellular that it can be missed quite easily. Thank you very much for your attention. Are there any questions? Yes.
So I saw one slide which shows that you use PCR method to detect the resident cells. Oh, am I understanding right?
No, that is not PCR. It is pathologic complete response. So that's not PCR. That's the abbreviation for pathologic complete response.
of DLBCL with centroblastic morphology. So here, majority of cells are large with these vesicular nuclei and some small nucleoli attaching to the nuclear membrane, which is characteristic for centroblastic morphology. So this is a picture. Actually, it's not large B-cell lymphoma, but I think it represents immunoblastic morphology quite nicely. So the cells here are still large with round nuclei. So with central prominent nucleoli and amphiphilic cytoplasm. So the morphological variants sometimes correlate with subtyping based on the gene expression profile, which I will talk about later, but they do not always correlate. In the current 2008 WHO classification, there are many entities listed under large B-cell lymphoma. Even under the DLBCL, not otherwise specified, there are 4 entities. So just based on that, you can see large B-cell lymphoma is indeed a heterogeneous disease. Based on gene expression profile, the START group has classified DLBCL into mainly 2 groups, the germinal center B-like DLBCL and activated B-like DLBCL. The GCB-like DLBCL has a gene expression profile similar to the germinal center B cells. The activated B-like DLBCL has an expression profile similar to activated B cells. So to understand this classification better, I would like to briefly talk about B-cell development. So the B cells develop from stem cells in the bone marrow. After maturation, they circulate in the peripheral blood as naive B cells. Then those naive B cells colonize peripheral lymphoid tissue, such as lymph node in the lymphoid follicles. Then naive B cells go into germinal center and interact with antigens. And they finally exit germinal center and develop into plasma cells and memory B cells. So the plasma cells and the memory B cells can recognize specific antigens. The GCB type DLBCL are derived from cells in the germinal centers, and the ABC type DLBCL develop from cells exiting the germinal center, but before developing into the plasma cells. Previous studies of molecular mechanism in B-cell lymphomas have focused on chromosome rearrangements, especially the immunoglobulin heavy chain gene associated translocations. These studies have resulted in identification of important genes such as BCL2, BCL6, and MYC. Almost all of these genes are upregulated by IgH-associated translocations. Identified a novel IgH-associated translocation, which actually results in the inactivation of the partner gene, which is BANK1. BANK1 stands for B-cell scaffold protein with anchoring repeats 1. BANK1 deficient mice show enhanced germinal center formation and IgM formation in response to T-cell dependent antigens, and increased CD40-mediated survival and proliferation of B cells with enhanced AKT activation. So CD40 is an important molecule that can activate B cells when interact with antigens. And the AKT pathway is known to promote cell survival and proliferation. BANK1 seems to inhibit CD40-mediated AKT activation, which in turn can inhibit cell proliferation and survival. So it seems BANK1 has a tumor suppressor function. So currently, functional study of BANK1 is undergoing. With the development of new technology, many more genes have been identified that are associated with development of DLBCL. EZH2 mutation was discovered by next-generation sequencing. Subsequently, 20% GCB DLBCL cases have been found to have a EZH2 mutation, and the mutations in EZH2 are almost never seen in ABC-type DLBCL. EZH2 is involved in mutations are gain of function mutations, which increase methylation of histone 3 and subsequently suppression of the downstream genes. Studies of potential agents targeting BCL6 and EZH currently underway. I'm sorry, I think this is the older version of my presentation, so that's a typo on that. In addition to the loss of PTEN expression was found in even higher percentage of the GCB type DLBCL, while in the non-GCB type DLBCL, only 14% of cases have been found to have loss of PTEN expression. PTEN is a non-tumor suppressor gene. Inactivation of PTEN results in constitutive activation of the PI3 and AKT pathway. Currently, the mainstay of therapy for DLBCL is R-CHOP, which stands for rituximab, cyclophosphamide, doxorubicin, vincristine, and prednisone. Rituximab is an antibody against CD20, which B cells. The addition of rituximab has greatly improved the DLBCL outcome. However, ABC-type DLBCL still has significantly inferior outcome compared with the GCB subtype. So obviously, novel therapeutic agents are needed for ABC-type DLBCL and for relapsed DLBCL, which has a worse outcome. So as I mentioned previously, ABC-type DLBCL derives from B cells at a plasmablastic stage prior to germinal center exit. It has been demonstrated that ABC-type DLBCL is characterized by constitutive activation of NF-kappa B signaling pathway, which can promote cell survival, proliferation, and inhibition of apoptosis. In addition to the NF-kappa B pathway, JAK kinase signaling pathway is also activated. Previously, it was not known how these pathways were activated in the ABC-type DLBCL. A loss-of-function RNA interference screen has identified important genes such as CARD11 and MALD88. CARD11 is a gene involved in B-cell receptor signaling, and MALD88 is involved in Toll-like receptor signaling pathway. Subsequently, mutations have been identified in many genes in the B-cell receptor signaling pathway, which can result in chronic active B-cell receptor signaling. Other mechanisms that can activate NF-kappa B signaling pathway include gain of function mutations in the positive regulators of the NF-kappa B signaling pathway, such as CHF-MAP3 kinase gene mutations, and the loss of function in the inhibitor of NF-kappa pathway, such as the A20 gene. So this is more or less a summary of the molecular mechanisms that result in the NF-kappa B signaling pathway activation in the ABC-type DLBCL. The activation of the genes involved in B-cell receptor signaling pathway and Toll-like receptor signaling pathway, including the interleukin, can activate I-kappa B kinase. The activation of I-kappa B kinase results in the phosphorylation of I-kappa B, and the degradation of that molecule. I-kappa B is known to inhibit NF-kappa B activation. In addition, the loss of A20 inhibition can also activate NF-kappa B. So it seems there are multiple pathways in the ABC type DLBCL that can result in the NF-kappa B signaling pathway activation. In addition to the NF-kappa B pathway, other mutations have also been identified in the ABC type DLBCL. PRDM1 is a gene identified as a positive regulator domain binding factor. It is a master regulator for terminal B-cell differentiation and is required for the formation of plasma cells. PRDM1 is activated by mutations and deletions in about 25% of activated B-cell like DLBCL. Mice with disruption of the PRDM1 gene are predisposed to lymphoma, which are analogous to ABC type DLBCL in humans. In addition, it was found that constitutive activation of NF-kappa B can cooperate with inactivation of PRDM1 in the development of lymphomas in mice. So it seems both activation of NF-kappa B and inactivation of PRDM1 can cooperate in the development of ABC type lymphoma. So with the understanding of all these molecular pathways, novel therapeutic agents targeting NF-kappa B signaling pathway or the B-cell receptor signaling pathway have been evaluated and have shown promising effects. Bortezomib is a protease inhibitor which blocks I-kappa B alpha degradation. It has shown benefit for ABC type DLBCL in relapsed patients. Trials are currently undergoing to addition of bortezomib to R-CHOP in untreated patients. Many reagents targeting B-cell receptor pathways have also been evaluated. Ibrutinib is a BTK inhibitor, which has shown response in relapsed ABC type DLBCL. Fostamatinib is another kinase inhibitor. A response has been demonstrated in refractory DLBCL. BCL2 is overexpressed in both ABC and GCB type DLBCL, although with different mechanisms. ABT99 is a selective inhibitor of BCL2, which has shown good response in the refractory DLBCL. Lenalidomide has been shown to have multiple functions, including immunomodulatory effect and NF-kappa B inhibition. It has been shown to have 30% response rate in relapsed or refractory aggressive lymphomas. Lenalidomide preferentially is active in non-GCB type DLBCL. So, in conclusion, DLBCL is biologically heterogeneous. ABC and GCB type DLBCL are distinct entities with different molecular mechanisms. GCB type DLBCL is characterized by constitutive activation of NF-kappa B pathway. Many new therapeutic agents are currently under evaluation targeting different molecular pathways and have shown results. So hopefully in the future, we will have better outcome for the ABC type DLBCL. That's all. Thank you for your attention, and I will take questions. Thank you.
lymphomas is going to be Dr. Andreas Rodrigues Cardovil-Pires from Fonte Medicina Diagnostica in Brazil. The title of the paper is EBV positive, diffuse large B-cell lymphoma of the elderly, chromogenic in situ hybrid, and immunohistochemistry using tissue microarrays. I'm the moderator, as you noticed, and Dr. Guy had to catch a flight.
Hello, good afternoon. I would like to thank the organizers for the opportunity of being here today talking with you. I'm Andrea Pires, and I'm from Fonte Medicina Diagnostica. I'm a pathologist. And so we're going to talk about EBV positive diffuse large B-cell lymphoma. It's not here. Okay. No problem.
Again, we are
no problem. Oh, EBV positive large B-cell lymphomas are one of the subtypes of diffuse large B-cell lymphomas, and is characterized by proliferation of EBV positive cells. Okay. Occurring in patients with no prior history of lymphomas or any immunodeficiency. It accounts about 8 to 11% of lymphomas and less than 5% countries. And this increases with age. Well, our work was look for EBV positive diffuse large B-cell lymphoma in a tissue microarray with 80 cases of diffuse large B-cell lymphomas. And we used a technique called TMA-4O method that we designed, and we performed this quiche technique for EBR1 and EBR2 RNA and immunohistochemistry for molecular classification. Well, the technique we used to build the TMA was designed by us in 2006 and published, and it's a very cheap method. We basically cut out the point of a conventional hypodermic needle with a drill machine. After we cut the point, we make a lateral opening and then sharpen the flat point to cut the paraffin blocks. This needle, so we are using to punch the donor blocks, and we can do this with a hand press or we obtain will be placed in a paraffin mold and using a double-sided adhesive tape to align in lines and columns. Below the adhesive tape, we put a paper grid with small dots so we can design how many columns and lines we want, and also the distance between the cores. So aligned and attached to the adhesive paraffin and have a nice paraffin TMA block. This technique is very interesting because all tissue pores are at the same plane. So even in the first cuts, we have all tissue present. Here is a large TMA we did. It's 325 paraffin pores. Here is the mold. Here we have the paraffin block ready and the corresponding agent slide. And we also published this in a book about tissue microarray techniques. For hybridization, we use Cytofast EBV probe against EBR1 and EBR2 probes. And for molecular classification surrogate immunohistochemistry, we use the Hans algorithm. There are several algorithms used today to make
make this classification, and we use hands. So we analyzed 80 cases, only 3 for IBV, and all these 3 patients were over 50 years old. 2 were men, 1 woman, and all of them had extranodal disease, stomach, bone marrow, and mediastinum. 1 was ABC type, the other was germinal cellular type, and the other was not classified, probably ABC type. Here's the morphology and immunohistochemistry for case 1. MUM1 was not available for this score, that's why it's interrogated. It's non-germinal centered B type, CD20, CD10, BCL6. Here's the case 2, a non-GCB type also, an ABC, EBV positive, SCISH, CD10, BCL6 negative. The third case, we had EBV positivity and CD10 and BCL6 positivity. This case had no MYC translocation by FISH. So, EBV positive diffuse large B-cell lymphoma is characterized by the activation of classical and alternative pathways of NF-kappa B, most cases showing ABC pattern. Prevalence is over 50 years old and extranodal location. All our patients fulfill these characteristics. It's interesting that besides all positive cases in this TMA correspond to all these characteristics, the age of 50 years is arbitrary. A few weeks ago, we went to a conference, an impact conference, with several of the authors of the WHO classification, and they told that next year, the review of the classification, probably this name of the elderly will no longer be used. So it will be just EBV positive diffuse large B-cell lymphoma, because it's growing the number of cases of younger patients positive. So concluding, the recognition of EBV positive diffuse large B-cell lymphoma, regardless of age, it's important because of the new therapeutic approaches targeting not just NF-kappa B, but also EBV that can be good for this patient that have now worse prognosis. That it.
For the concise and informative presentation, the paper is open for question. Next, we are going to give the awards at the end, and the next will be Dr. Munaf Desai from Al-Qasimi Hospital in the United Arab Emirates. The title of the paper is the use of immunohistochemistry in formidable biopsy of breast, a real experience at Al-Qasimi Hospital, Sharjah. Indeed.
It's going to be on one of these folders right here.
It's slide 7, all right. Track.
Good afternoon, everyone, and thank you very much, organizers, for giving. Title of my presentation is Use of Immunohistochemistry in Core Needle Biopsy of Breast, 2 years experience at Al-Qasimi Ministry of Health, Sharjah, United Arab Emirates. Al-Qasimi Hospital is a Ministry of Health hospital and a reference center for My presentation is a little longer, but I will try my best to finish it in the given time. Now, breast core needle biopsies have replaced the older procedure like fine needle aspiration cytology or surgical biopsies due to advanced radiological techniques and more organized, widespread breast screening program. And in these cases, immunohistochemistry is now almost mandatory. However, the gold standard for reaching the correct diagnosis remains basic H&E morphology and its correspondence to immunohistochemistry finding. In our department, we receive breast core needle biopsies from two different sources: National Breast Screening Center, Abu Dhabi, and Sharjah Kuwaiti Hospital. The cases are either screen detected or symptomatic, and patients' origin is quite diverse, representing more than 20 nationalities, including United Arab Emirates nationals. Ages ranging from 32 to 73 years. And in this study, we have looked at the role of multiple immunohistochemistry markers in total 74 breast core biopsy specimens received over 2 years between 2013 and 2014, and have also compared different myoepithelial markers for their efficiency and usefulness when used either alone or in combination. Methods. The histopathology records of the all breast core biopsy cases reported between January 2013 and December 2014 at our department were reviewed to find out total number of cases, spectrum of the diagnosis, and role of immunohistochemistry in each case. Standard protocol for fixation, processing, preparation of the slides, and for use of controls were followed. Prognostic and diagnostic immunohistochemistry markers were run at the time of reporting the cases as a routine procedure at free of cost to the patients and also not at extra cost to Ministry of Health. Whatever antibodies we were having, we utilized that without extra demand. For first 80 cases, Ventana, and for remaining cases, a DACO system were used. The selection of the system was based on the supply of the antibodies to our department. Incidence of prognostic markers in the malignant breast core biopsy cases were checked and were available. Their corresponding results of mastectomy or excision biopsy specimens were obtained and compared with the breast core biopsy results. Details of the diagnostic markers in these cases were extensively evaluated for their usefulness in differentiation of benign and malignant cases, for their use in identification of the type of breast cancer, and for comparison of the results of different myoepithelial markers. Results. Total 174 cases, out of that 101 were benign, 63 were reported as malignant, and 10 cases were benign with atypical changes. These are the list of malignant cases. Highlight is 39 cases were invasive ductal carcinoma of no specific type, and we also received some special type of carcinomas, breast carcinomas. That is a mucinous carcinoma, metaplastic carcinoma, invasive papillary carcinoma, and adenoid cystic carcinoma. These are 10 atypical cases. I am not going in detail of this table. These are the benign cases. Out of 101, main diagnosis in benign cases was sclerosing or a simple adenosis or columnar cell lesions. We also reported 18 fibroadenomas on core biopsies, 5 phylloides tumor, and 1 inflammatory myofibroblastic tumors. In this 174 cases, we also received 2 samples from male patients which were reported as gynecomastia. Now, breast prognostic breast prognostic markers in 61 cases. Out of 63, we did breast prognostic markers in 61 malignant cases. In 2 we could not do because of some technical issues. In this 61, ER was positive in 41 cases and negative in 20 cases. PR was positive in 39 cases and negative in 22 cases. HER2 was positive in 7 cases, negative in 31 cases, and equivocal in 23 cases. Incidence of ER/PR in malignant cases in 36 cases, ER/PR both were positive. In 7 cases, ER was positive but PR was negative. In 16 cases, ER/PR both were negative, and in 2 cases, ER was negative and PR was positive. Out of this 174 cases, only in 9 cases we received subsequent surgical specimens. But we did the comparison of result of breast prognostic markers on core biopsies and in the corresponding surgical specimen in these 9 cases. And what we found is results of ER, where the concordance of the results in ER was 100%, but in PR and HER2 it was 78. In ER, all results were matching with both subsequent surgical specimens. In PR, 2 discordant results were there, and in HER2 also 2 results were discordant. This slide shows our results of our breast prognostic markers. ER diffuse strong positive, then PR, that is the columnar cell lesions, strong diffuse positive. This slide is showing HER2 +1 negative. This is HER2 +2 equivocal, and this is HER2 +3 positive. In 81 cases, we used myoepithelial markers, and initially we were not having a P63 and smooth muscle myosin heavy chain. So in 61 cases, we used SMA alone, and 47 of them were benign, 5 were in situ carcinoma, and 9 were malignant. In 9 cases, we used P63 alone. 6 of them were benign and 3 were invasive malignancy. We used smooth muscle myosin heavy chain alone in 1 case, and that was a malignant case. We used combination of smooth muscle actin, P63 and smooth muscle myosin heavy chain in 2 cases. One of them was benign and other was malignant. We used combination of smooth muscle actin, P63 in 6 cases. 3 of them were benign, 1 was in situ carcinoma, and 2 cases were invasive malignancy. We also used CD10 in 2 cases with combination of SMA and smooth muscle myosin heavy chain, and 1 of them was benign and other was malignant. We also used basement membrane marker collagen 4 in 81 cases, and out of that 58 were benign, 4 were DCIS, 2 were papillary DCIS, and 17 were invasive malignant. This slide is of sclerosing adenosis. On H&E, this was really confusing. It was difficult to differentiate invasive carcinoma in that, but use of myoepithelial marker helped in this case. We can see presence of myoepithelial cells on this SMA slides and intact basement membrane around all ductal component in collagen 4. And here we can compare the results of smooth muscle myosin heavy chain and P63 is a nuclear positive and without background positivity. So interpretation is better in P63. Same way smooth muscle myosin, it is a cytoplasmic marker for myoepithelial cells, but interpretation is better than smooth muscle actin. This is a case of papillary DCIS intracystic type. Here we can see this complex papillary pattern, and it is showing strong diffuse positivity for ER, and myoepithelial cells are negative in the papillary pattern. Basement membrane is also negative, so it is supporting the diagnosis of DCIS. And here we can see that smooth muscle actin, in smooth muscle actin we can see that myoepithelial cells are absent at the periphery of the lesion, but basement membrane is intact, so it is a intracystic type of papillary DCIS. This is a case of a tubular carcinoma of breast. You can see that on H&E, angulated neoplastic tubules are there, but it was very difficult to confirm it as a carcinoma on only H&E findings, but smooth muscle myoepithelial helped it cells in these slides. But here again we can see that use of SMA is sometimes difficult. It also stains the myofibroblast of the stroma, and like in this case, only on SMA it was very difficult to identify this neoplastic glands. It may give false positive results for myoepithelial cells. We used E-cadherin in 56 cases, and it was positive in 51 and negative in 5 cases. This first slide is an example of invasive ductal carcinoma, which is positive for E-cadherin. Second is H&E of DCIS on differential diagnosis was lobular carcinoma in situ, but E-cadherin is a diffuse membranous positivity of the E-cadherin confirmed DCIS diagnosis. We also used ER in benign cases to identify columnar cell lesions and to differentiate atypical ductal hyperplasia from usual ductal hyperplasia. And we found that in 14 cases it was heterogeneous, and in 6 cases it was strong diffuse positive. Here we can see first 2 slides from flat epithelial atypia, second is of columnar cell changes, and last one is columnar cell hyperplasia. We can see high molecular weight cytokeratin in all type of columnar cell lesions, and ER is strong diffuse positive in all columnar cell lesions. BCL2 positivity can also help to confirm columnar cell lesions. I also used some other markers in some occasional situations. I am not going into this detail of this table, but I will discuss each marker and its importance in a discussion. This is a case of mucinous carcinoma. It is positive for NSE, so it can endocrine differentiation of this tumor. This is a fibroepithelial lesion. On H&E, my differential diagnosis was schwannoma because some palisading pattern and thin wavy nuclei were there. But S100 helped me to rule out schwannoma in this case, and I reported it as a fibroepithelial lesion, most likely benign phyloides, and on excision it was a benign phyloides tumor. CD31 can also help in some difficult situation to confirm vascular invasion. Sometimes to identify lobular carcinoma is very difficult, like in this there was a scanty component. It was like very confusing that whether these are lymphocytes or neoplastic lobular carcinoma cells, but use of cytokeratin cocktail, CK-MNF or CK can help in this case. Here we can see that CK-MNF is positive in stromal component, so it is a invasive lobular carcinoma. This case I received core biopsy with BIRATS 4B radiologic diagnosis. but it was showing well demarcated lesion with some connecting spaces. And when I did CT were positive, so it was a vascular tumor and there was no ATP, so I reported it as a angiomatous tumor without nuclear atypia, most likely capillary or sinusoidal hemangioma. This is a case of adenoid cystic carcinoma of breast. An important point is in this carcinoma, P63 will be positive in tumor cells. We can see this and P63 tumor cells, and this intraluminal this material is positive for collagen 4. These two important points to support the diagnosis of adenoid cystic carcinoma, and we can by this we can differentiate it from invasive cribriform carcinoma. Now, we routinely perform breast prognostic marker on, and it is important for selection of patients for neoadjuvant therapy and also in adjuvant chemotherapy. Surgical biopsies is ER, PR and HER2, and in fact in one study has suggested that ER, PR assays are more reliable on breast core biopsy specimens than on excision or resection specimens. Our findings are also matching with this previous study. All of our patients were with malignant either in UAE or overseas for further management, as we don't have oncology department. So in most of the cases, subsequent excision or a resection is also done at other centers. So this is also a reason to do breast prognostic markers on all malignant core biopsy cases. And another important point, that if a very small tumor completely removed by breast core biopsy, and that is possible, then the subsequent surgical specimen will not show any residual tumor component, and this is also an important indication to do breast prognostic markers on core biopsy specimens. Use epithelial markers and basement markers in breast core biopsy specimen is for distinction between invasive and in situ lesions, for differentiation of non-neoplastic proliferating lesions like sclerosing adenosis or radial scar from invasive carcinoma, for differentiation of intraductal papilloma from papillary DCIS or intracystic papillary carcinoma, and a special type of breast carcinoma, for example, adenoid cystic carcinoma or metaplastic carcinoma or adenosquamous carcinoma. Absence of myoepithelial cells and basement membrane can confirm the invasion. In 61 out of 81 cases, we used only smooth muscle actin because P63 and smooth muscle myosin were not available, were introduced in our department very late in 2014. And smooth muscle actin, which as a myoepithelial marker, if other markers are not available, but special care should be taken to avoid false positive interpretation, as smooth muscle actin can stain stromal myofibroblast. We found use of P63 and smooth muscle myosin heavy chain more reliable than SMA, and our observations are also matching with those of the previous studies. Collagen 4 can support the results of myoepithelial markers and is also useful in detection of microglandular adenosis. In microglandular adenosis, myoepithelial cells are absent, but basement membrane is present. Classification of papillary lesions of the breast on core biopsy can be done with more confidence by using myoepithelial cells and basement membrane marker. P63 is also used for identifying two special types of breast carcinomas, adenocystic and metaplastic adenosquamous carcinoma. Calponin is also a good myoepithelial cell marker with high specificity and sensitivity, but it is not available in our department. We tried CD10 in 2 cases, and we did not use high molecular weight cytokeratin or S100 as myoepithelial markers because of their low specificity. E-cadherin can help in differentiation of ductal carcinoma from lobular carcinoma or from atypical lobular hyperplasia from usual or atypical ductal hyperplasia. P120, a positive stain for lobular carcinoma, is also a useful marker for this differentiation, but not available in our department. It is more useful in identification of the mixed carcinoma. Now, role of immunohistochemistry in tumor type identification. Like already we discussed that P63, collagen for CD117 and smooth muscle myosin heavy chain are useful for confirmation of adenoid cystic carcinoma. P63 can help in identification of metastatic breast carcinoma. Vimentin positivity can be seen in high-grade ductal carcinoma or medullary carcinoma. ER, high molecular weight cytokeratin and or BCL2 can be used in columnar cell lesions. Chromogranin, synaptophysin or NSE are useful to rule out or confirm carcinomas with neuroendocrine features. We found NSE positivity in mucinous carcinoma. Smooth muscle actin, desmin, CD34, CD31, beta-catenin, ALK1, S100, CD99 and vimentin are helpful in differentiation and diagnosis of mesenchymal lesions or tumors of the breast. Use of Milan A may be needed, especially in melanoma, to rule out or to confirm metastatic melanoma. Now, use of immunohistochemistry for differentiation of usual ductal hyperplasia versus atypical ductal hyperplasia and in situ carcinoma. High molecular weight cytokeratin antibodies like 34 beta E12 or CK5-6 or CK5 show strong diffuse reactivity in usual ductal hyperplasia and in ductal epithelial hyperplasia of papilloma. But high molecular weight cytokeratins are negative in atypical ductal hyperplasia and in most of the low or intermediate grade DCIS. And ER is negative for or focally positive in usual ductal hyperplasia, but it is usually diffuse strong positive in atypical ductal hyperplasia or and in low or intermediate grade DCIS. However, this high molecular weight cytokeratin and ER panel is not valid for making this differentiation in columnar cell lesions and in apocrine DCIS. Atypical apocrine adenosis. Most of the columnar cell lesions are negative for high molecular weight cytokeratin and show strong diffuse positivity for ER. So, high molecular weight cytokeratin and ER cannot differentiate columnar cell changes or columnar cell hyperplasia from flat epithelial atypia. And same in apocrine DCIs and in atypical apocrine lesions are usually negative for ER and they may express cytokeratin 5. Ki67 is useful in differentiation of benign, borderline and malignant phylloides tumor. Ki67 can also be used in columnar cell lesions because in flat epithelial atypia it is usually less than 5% and in high grade DCIs it is more than 20%. And we don't use Ki67 as a prognostic marker in malignant breast cases. Sometimes use of CD45 and cytokeratin A1, A3 is helpful in differentiation of lymphocytic infiltrate from invasive lobular carcinoma in some difficult situation. A1, A3 or CKMNF can be used for identification of metastatic carcinoma, particularly in metastatic lobular carcinoma in lymph node to save the time. This study explains the need of immunohistochemistry in breast core needle biopsy specimens for diagnostic and prognostic purposes.